কালকে শুধু সুখদেব মানা বাচ্চার কাছে যাবে।
Please take a screenshot of whoever is there.
Yeah, I've already taken it.
Oh, great, thank you.
We are live.
Great. Good evening, welcome everyone. Dr. Sapan Samanta is here, Dr. Verma is here as the judge, and Dr. Chakravarti. So may we request the first candidate to start 4 minutes. Your mic and your screen will be cut off after 4 minutes. Dr. Sumit, may I please request you to do that?
Yeah, I'll do that.
For this session. Thank you so much. So should we begin?
So,
may I share my screen, ma'am?
yes, Dr.
Yeah,
Rashmi.
your time starts when your screen starts, okay? All the best.
Thank you. Ma'am, is it visible?
Yes.
Yes.
It's visible.
Okay, shall I begin, ma'am?
Yes, please.
Doctor, please can you start the time? Thank you.
Yeah, sure. I'm keeping it.
Good evening, everyone. My name is Dr. Rashmi from Dr. B.R. Ambedkar College, Medical College, Bangalore. My topic for today is to analyze retinal nerve fiber layer thickness in emmetropia, myopia, and hyperopia by spectral domain OCT. So refractive errors such as myopia, hyperopia, astigmatism, they affect a large proportion of the population worldwide. It's one of the most common ocular problems. And according to the WHO, it is the most common cause of visual impairment and cause of visual loss worldwide. As we can see, the burden is huge and uncorrected errors can have immediate as well as long-term consequences in the population, such as lost educational employment opportunities, lost economic gain for families, societies, and an impaired quality of life.
Students.
This graph shows the prevalence of vision impairment in the population globally in the year 2020. And this graph here shows the prediction that millions more are going to be affected by these refractive errors by the year 2050. As we can see, it's only getting increasingly worse. So this study dealt with checking the RNFL layer. It's highly reflective on OCT images, and we can, using computer algorithms, we can automatically segment and measure this layer. So this helps to detect many ocular diseases in the early stages like myopia, glaucoma, and several other conditions also. So this OCT, the advantage is that it non-invasively images detailed ocular structures with a high resolution, and we can do it in vivo in real time. And so the advantage being we have ease of use, reproducibility, and safety and repeatability as well. And this is the basic principle. It's based on low energy, low coherence interferometry. And the objectives of the study was we wanted to measure the retinal nerve fiber layer thickness in these 3 groups, that is emmetropes, myopes, and hyperopes, to see whether there's any variation, and also to evaluate the influence, if any, that axial length had on the measurement of the RNFL layer. So it was a prospective observational study which lasted for a period of 18 months. We used 50 patients who fulfilled the inclusion and exclusion criteria, who visited our OPD and IPD at Dr. B.R. Ambedkar Medical College. And so we had the inclusion criteria being age group of 15 to 30 years, those with emmetropia, myopia of -0.5 diopters to -4 diopters, those with hyperopia +0.5 diopters to +4 diopters, and those who are cooperative and willing. In the exclusion criteria, anyone outside the age group was excluded, those with astigmatism, any media opacities which would interfere with the imaging, any retinal macular diseases, pseudophakia, aphakia, cataracts, or keratoconus. And this is how we had done the scans. And so the results were the subjects were divided into their spherical equivalent groups, that is emmetropia group, myopia group, and hyperopia group. We used both the eyes for statistical analysis. And here's a graph that shows the distribution of the mean RNFL in the right eye as well as the left eye in the 3 groups, emmetropia, hyperopia, myopia. And this is the other graph that shows the distribution of the mean axial length among the 3 groups of the right as well as the left eye. The blue indicating the right and the green indicating the left eye. So in the study, we had a total of 50 patients. The mean age group was 23 years, and the number of male and female participants was 25 each. So we saw in the study that the average RNFL thickness was calculated in emmetropes, myopes, and hyperopes, and it was highest in the RNFL thickness was similar in the emmetrope and the hyperopic group, whereas it was lower in the myopic group. And the mean axial length was seen to be increased in the myopic group, whereas in the hyperope and emetrope group, it was closer. And so by statistical analysis that we saw that the mean RNFL thickness was lower in the myopic group as compared to the other two groups. And the mean axial length was higher in the myopic eyes as compared to the emetropic and the hyperopic groups. So the average RNFL thickness.
Time is up. Time is up.
Please stop straight away. May I go to the judges now? Dr. Chakrabarti ma'am, Dr. Divya Verma.
Dr. Divya, ma'am, please, can you ask the question?
Please ask. And excuse me, what is the name of the candidate?
Ma'am,
Dr.
Dr.
Ma'am, Rashmi.
Dr. Rashmi. May I request the judges to please give the marks in your sheet for Dr. Rashmi, because serial numbers may have gone up and down because of different candidates presenting at different times. So this evaluation will be for Dr. Rashmi. Thank you so much. May I request judges to please ask any question?
Yes, I have one question, Dr. Rashmi.
Hello, Dr. Rashmi.
Yes, sir. Yes, sir.
In which year are you studying?
Sir, final year, sir.
Final year, go. So, what is your inference?
So our study showed, sir, that in myopic group, the RNFL thickness was less as compared to the emetropic and the hyperopic group, sir. So we should scan. It would be useful to scan these people who are at risk, because we can catch early changes in these patients, sir, as OCT is a non-invasive method of evaluation.
Okay. Okay.
So Rashmi, I would like to ask, why this study? What the inference of this is helping in the future diagnosis? I mean, why you choose this actually?
Ma'am, we chose this because we have a refractive errors was the main complaint that people come with, and as we have seen from the studies, the refractive errors are only increasing, and the burden, the global health burden of visual impairment is only increasing. And by
do you think that patient first come and we directly go to get it done OCT of all the patient before doing that refractive error? I mean, refractive error correction. I mean, refraction is in itself is a better thing to diagnose with, which is I mean, myope and hypermetrope. So what additional value this study is giving to the, I mean, I want to ask.
Yes, ma'am. Refractive error itself is definitely a risk factor, ma'am. But in this, we wanted to see whether there was an association between the refractive error and the retinal nerve fiber layer. So if there's any optic nerve, any sort of pathology, that we can catch it early, because those with myopes are already higher risk for glaucomatous changes or visual field defects. So we thought if we could do this study and we see that we can, if there is any difference, we can catch those at risk earlier, so we can scan them at an earlier age than we would normally do by standard protocol, only if they come with a symptom. So before they do, and if they have a higher risk.
So you are suggesting that we need to do OCT of every myope patient, because that is positively related, because there are definitely there is a high chances of POAG or open angle glaucoma in the myopes.
If they are at if it is a higher if they are at the power or their refractive error is greater, like if it's moderate to severe, it would be of some benefit to screen them. Not for the mild impairment, ma'am, but for the moderate to severe, we felt it would be useful to check.
What else you I mean, expect to suspect that other than glaucoma, what else can be happen if the RNFL is, you know?
So they could have any other visual field defects. Incidence of macular holes also is more. Incidence of serious retinopathy or any of those causes, they tend to be higher in these cases, ma'am. So we just thought that it would be useful to know when these patients are high risk, and we can screen them specifically for those ocular diseases, any of edema, macular edema, or any of this, you can catch in the early stage before they actually have any serious damage.
Okay, so this is of more important in myopic patient, not in hypermetropes and emetropes. So you said
Yes, ma'am, because according to the study, we found that their RNFL thickness was quite healthy. It was good. It was within it was a good range. So we feel that we could do that only for the myopic group. Because
Thank you, Dr. Rashmi. We need to move forward because
Yes,
time
sir.
is up
Thank you,
for
sir.
the
Thank you,
questions
ma'am.
also.
Thank you.
May I request the judges to please keep the scores as Dr. Rashmi, and at the end of this session, the scores may be shared with Mr. Amit of ACOIN or put in the group. Dr. Samantha, sir, can we put in the judges group the scores at the end of the session, the total for each candidate?
The judges can have their own group because then they can,
No, we have a group for the judges. There is a group.
There is a group for the judges, then they can post it in that group.
Okay, so please may you post it. Thank you. Next, who is the next person? We may write down the name for the evaluation. Next, Dr. Monica.
Is there I'll just see who's there. It is Dr. Shubhankar Paul. Is he here? Is Dr. Shubhankar here? Dr. Shubhankar?
Otherwise, we'll go on to the next person, Dr. Smith.
Yeah. Dr. Shubhankar is not there, then Dr.
Those who are absent, I don't think we should allow them to present because they have to be present.
Pritisha Goswami.
Kritika?
Pritisha.
Okay. Are you there, Dr. Goswami?
Dr. Pritisha? They're not there. Dr. Vishal Advani. Dr. Vishal Advani. I hope they got the message that they
all got 20,000 messages and so many phone calls we've received. Next one.
Dr. Alok Sharma. Dr. Alok Sharma.
I think Dr. Alok Sharma is there as the audience. Can we make him a panelist? I've seen the audience. Some Dr. Alok Sharma is there. The attendees.
But he should not have got that. He should have.
No, I think I will allow him to talk. Change role to panelist. I've changed it. Dr. Alok? Dr. Alok?
I'm just upgrading, Dr.
Okay, you are the participant, right?
Dr. Alok is, I'm asking to unmute.
Yeah, Dr. Alok,
yes,
please.
Good evening, sir.
Good evening,
so
Dr. Alok.
Please start your presentation. And Dr. Smith, will time the moment his screen starts, right?
Yes, ma'am. Just let me share this PPT, ma'am.
You are one of the participants, right?
Right, ma'am. That's right.
Okay. Now I'll see any other attendee who's there. Let me just check.
You are Alok?
Yes, yes, sir.
Okay, you are which year? Final year?
No, sir. JR2, sir. Second year PG.
Second year. Okay.
So shall I begin, sir?
Yeah,
Dr. Smith, then the moment he starts, please do the time. Thank you. Judges, please give the scores for Dr. Alok after you. Thank you.
Yes.
Please do.
Good evening, everyone. Today I'll be presenting about a 45-year-old male patient who's a known case of hypertension who presented with complaints of mild headache with pain on the right side of the neck for last 1 month. He also gave a history of severe vomiting and diarrhea since 2 days, for which he was hospitalized prior to the onset of symptoms. On examination, vision was normal in both the eyes, along with ocular motility and anterior segment findings, along with pupillary reaction were normal. Fundus examination showed bilateral papilledema. Apart from that, patient, since he was complaining of persistent pain in the right side of the neck, there was tenderness along the medial side of the sternocleidomastoid muscle on right side. The rest of the systemic examination were normal. We did the MRI, which was least sensitive, followed by MRV, which showed lack of flow involving posterior superior sagittal sinus, extending to right lateral sinus and sigmoid sinus, which was suggestive of thrombosis. Hemogram, blood chemistry, and profile for connective tissue disorders were normal. Coagulation profile, surprisingly, was also normal. So we came to the diagnosis of benign intracranial hypertension. This simple clinical sign of tenderness along the internal jugular vein in a case of benign intracranial hypertension suggests venous sinus thrombosis of lateral and sigmoid sinus, which is extending into the internal jugular vein as a cause of raised intracranial pressure. The conclusion was papilledema with tenderness along the internal jugular vein can be presenting sign of lateral and sigmoid sinus thrombosis. The thrombosis of the lateral sinus is almost always septic. However, aseptic lateral sinus thrombosis may occur. The most common cause of septic lateral sinus thrombosis is chronic otitis media. The infection spreads to the dural sinus by direct invasion from mastoidea cells or via the emissory vein. When the thrombus extends into the internal jugular vein, it presents clinically as pain in the neck along the sternocleidomastoid muscle. Thank you.
Very good. Very good.
Nice and top in time. Yeah.
Thanks,
May I
sir.
request the judges? There was one column also for finishing on time.
Yeah.
Yes,
Thank
yes,
you.
yes. I have some question to the to Alok.
Yes,
Dr.
ma'am.
Alok,
Yes, ma'am.
can you
Good evening,
tell me why you are talking about benign intracranial hypertension where there is so much of these things. There is a definite disease and you are talking about benign. Do you think this is the true nomenclature?
Ma'am, good question. Actually, the thing is, ma'am, the cases of benign intracranial hypertension directly goes to the neurology department. However, the peculiar feature which got our attention was the papilledema, which was incidental finding in this case. If we go to the Dandy criteria for the benign intracranial hypertension, it goes with raised intracranial pressure, tinnitus, headache, and papilledema. However, this kind of criteria.
Okay. What is the recent nomenclature of BIH?
Ma'am, empty sinus syndrome, ma'am, empty sella syndrome, ma'am, and
benign intracranial hypertension. What is the current nomenclature?
Ma'am, idiopathic intracranial hypertension, ma'am, IIH.
Do you think in your case it is idiopathic?
No, ma'am. Actually, since the patient, no, ma'am, there is a reason behind this, ma'am. Since the patient had history of multiple episodes of vomiting, diarrhea, so we are suspecting
a separate category. So this is a separate category, not exactly that. IIH has two groups. One is the primary, one is the secondary. This is the secondary causes of IIH. What is the common clinical features in the case of IIH?
Ma'am, patient usually complains of headache, ma'am, which
what is the usual age group of this patient?
Ma'am, the age group ranges between 40 to 50 years of age group, ma'am, with female preponderance, which ranges from 3:1. Yes, ma'am.
What are the drugs that can cause IIH?
Ma'am, drugs which can cause IIH, ma'am, antidepressants, which OCP, ma'am, oral contraceptive pills, ma'am. If the female is on triptans, ma'am, or the steroid. Am I audible, ma'am?
Yeah, thank you, Dr. Alok. The time is up for the judges also for asking.
Okay. Okay.
Yeah. Now we have Dr. Basita Sahu. I think the next speaker is Dr. Basita. Are you there?
Yes, sir.
Yeah, please start with your.
Yes, sir. So, is it visible?
Yes, it's visible. Please start.
Good evening, respected sir and ma'am, and myself, Dr. Bhashita Sahu from GMC Jagdalpur, and I'm here to give a case presentation on chemical injury and under the guidance of Dr. Chaya Shari, ma'am. Here we start. A young 18 years old male presented with the chief complaint of diminution of vision in left eye for 2 days and associated with pain and burning sensation. And as per the history given by the patient, he was apparently well before 2 days, and then he sustained splash injury by lime in left eye while painting the wall in his workplace. And the patient noticed diminution of vision, which was sudden in onset and not progressive in nature, associated with severe pricking type of pain, along with redness and burning sensation. and followed by washing with tape water by himself. And with his complaints, he went to nearest district hospital 7 to 8 hours after injury, where copious irrigation done with normal saline for 30 minutes under local anesthesia, and patient took treatment as follows. TD injection was given, doxycycline BD, tablet, ascorbic acid BD, prednisone locally, and atropine TDS, moxicillin 8 times a day. And after 2 days of taking treatment, he was referred to Medical College Hospital, Jagdalpur for further evaluation and management. Then there was no past history of any ocular trauma or infection, no relevant history of any medical illness or drug abuse, no history suggestive of any allergies, no relevant family history, personal history was also. On general examination, he was of moderate build, conscious, cooperative, afebrile, and all the vitals are within normal limits. On systemic examination also, all the systemic examination was within normal limits. And on local examination, the facial symmetry was found to be symmetrical and head posture was normal. In right eye, visual acuity was 6/6, but in left eye, it was 1/60, not improving with pinhole. Near vision and color vision was normal for both eyes for the patient. And on further examination, in left eye, mild swelling was there in upper and lower lid, and lashes are mated. And on conjunctival examination, there was subconjunctival hemorrhage with chemosis in the bulbar conjunctiva, and linear defect was also present at the junction of medial 1/3 and lateral 2/3 of the upper palpebral conjunctiva. Limbal ischemia was also present, involving from 1 to 7 o'clock and 9 to 11 o'clock position. Hours. And cornea, it was irregular inferiorly, hazy stromal edema with epithelial defect, and in the inferior quadrant, corneal sensation was decreased, vascularization absent, and fluorescence stain was faintly positive from 5 to 7 o'clock. Then anterior chamber depth appears normal, but rest details are not clear. Iris were normal, color was seen, but details can't be appreciated due to corneal haziness. Then on pupillary examination, pupil was single 6 to 7 mm in size with dilated under atropine, and direct and consensual for left eye was non-reactive. And lenticular examination also, it was transparency can't be assessed properly due to the corneal haziness. This was the picture on slit lamp examination. And then fluorescent stain of left eye. Then this is the right eye showing normal findings. And for further examination, IOP was well traced in left eye, and rest all findings are normal. And on fundus examination, all the findings were normal in the right eye, but in left eye, red glow was faintly visible. Cornea was.
Your time is up. Your time is up. The time is up. You can, the judges can ask the questions now.
Dr. Bhasita, good presentation. Can you please classify in which staging of this in your case, which classification will follow in case of an chemical injury, and your case in which grading it? That you have not mentioned, no? So please tell us what was the grading.
Dr. Bhasita.
Hello. Yes, ma'am. Yes, sir.
Yeah, please answer the questions.
Which classification currently we follow?
Dua classification is followed nowadays.
Very good. And yes, according to the Dua's classification, your case will, in which category you want to put it?
Ma'am, it will be a grade for chemical injury, a good to guarded prognosis, because more than 6 to 9 clock hours limbal involvement is there, and conjunctiva is also involved, 50 to 70%. Therefore, it is considered to be grade 4 alkali injury.
So, which one is a better prognosis, a acid or alkali injury?
Ma'am, acid injury.
Why?
Ma'am, because it leads to coagulation of proteins, so it forms a barrier between the different
Yes.
epithelium. Therefore, further penetration of acid is not possible after that barrier.
Good, very good. You said the intraocular pressure was raised. What is
Yes,
the
yes.
cause of raised IOP in your case?
Ma'am, first of all, the cation in the alkali reacts with the carboxyl group of the stromal collagen, and it leads to the stromal decrease in the stromal clarity and shortening and thickening of the collagen fibers. So this leads to the trabecular meshwork integrity, ma'am, change हो जाती है, और it leads to the release of prostaglandins, therefore increase in myopia.
Okay, okay. Just last question. If a patient
Yes, ma'am.
comes to you first within 24 hours, what is the best management you can do? Apart from the thorough wash, what should be the best management?
To give steroids.
No. Okay.
Washing.
We can
No.
move on to the next speaker now. Dr. Kritika, are
Yes.
you
Thank
there?
you, ma'am.
Dr. Basita, you can stop sharing your screen now, please.
Okay, sir.
Dr. Kritika is here. Is Dr. Kritika here? No. We go to the next. That is Dr. Samadrita Paul. Dr. Samadrita? Yeah.
Sir? Yes, sir.
Yeah, please. Can you start with your presentation?
Yes, sir.
Please share your screen first.
Is my screen visible?
Yes.
Yes.
Please start.
Sir, is my screen visible?
Yes, it is.
Okay, sir. Good evening to everyone. I am Dr. Samadrita from Jorhat Medical College. I will be presenting a case before you. My patient is a 35-year-old who presented to me with a chief complaint of pain in the right eye since 2 weeks and diminution of vision since 6 months. On elaborating the history, her right eye pain was insidious in onset, gradually progressive and dull aching in nature and moderate in intensity. It was associated with redness, photophobia, mild watering, and the diminution of vision was present since last 6 months, which was insidious in onset and gradually progressive in nature. There was no recent history of trauma, foreign body exposure, history of fever, drug allergy, symptoms of chest infection, GI symptoms, urethral discharge, or any ulcer. On past history, patient gave history of similar illness in the other eye 1 month back and in the same eye 3 months back, which was resolved conservatively. And she also gave history of gradually progressive low backache since last 10 years, which was associated with stiffening and limitation of movements, which has ultimately led to deformity of the spine. There is no history of any other ocular or systemic illness in the past. Her personal history was unremarkable, and family history, drug history, allergic history were normal. On general examination, patient was found to have kyphosis, stooping forward position of the neck with flexion deformity of the hip. And on systemic examination, her musculoskeletal examination revealed kyphosis, loss of lumbar lordosis with restriction of spinal movements. On ocular examination, her right eye showed best corrected visual acuity of PL negative with high IOP of about 43.4. And the cornea in the right eye was mildly hazy with presence of flare cells which were graded as +2, fixed mid-dilated not reacting to pupil was fixed mid-dilated not reacting to light, and pale optic disc. On slit lamp examination, the right eye showed the presence of dense iris pigments, presence of flare cells, and fixed non-reacting mid-dilated pupil. And in the left eye, there were few iris pigments seen. Blood investigations revealed mild microcytic hypochromic anemia with raised ASR-CRP, positive HLA-B27 along with mild increase in alkaline phosphatase. Radiological investigations revealed loss of cervical lordosis, dorsolumbar lordosis, and presence of dorsal kyphosis, multiple disc lesions along with degenerative changes. However, her sacroiliac joints were normal.
And the following treatment was given to her: prednisolone eye drops, 1 drop 6 times daily for 1 week, followed by gradual tapering to 4 times and 2 times, and atropine eye drops 3 times daily for 1 week, dorzolamide timolol combination for 1 week, and acetazolamide given orally for 5 days. And the patient was asked to review after 1 week and also to seek orthopedic consultation. Following orthopedic consultation, she was diagnosed to be a case of axial spondyloarthritis, for which she was treated conservatively and immediately put on physiotherapy from their side. On follow-up, at the end of first week, patient's symptoms had decreased and visual acuity remained same. IOP was reduced to 31.8. Anterior chamber cornea was clear. The iris pigments were present, and gonioscopy revealed an open angle. At the end of the second week, her symptoms were totally absent. Cornea anterior chamber clear, IOP further reduced to 23, and iris pigments further reduced. Patient was finally diagnosed to be a case of recurrent enteritis with locomotor optic atrophy of the right eye associated with axial spondyloarthritis. In our case, the patient had presented with 5 classical features of spondyloarthritis, that is long history of back pain associated with raised ESR, CRP, HLA B27 positivity, anterior uveitis, and arthritis. And finally coming to the conclusion that major 40% of patients who are presenting with anterior uveitis can have an undiagnosed spondyloarthritis. So their effective screening is very much important, so that early diagnosis can be made and treatment can be initiated at the correct time.
Thank you. Thank you so much. Can the judges ask the questions to Dr.
I think this time the other judges can ask, because if anyone.
Carry on, Dr. Chakraborty, carry on.
Okay.
Carry on.
So,
Yes,
Dr. Samadrita is a very good presentation. Your slides are also good.
Thank you, ma'am.
What is the gender predilection for this disease?
Ma'am?
What is the usual gender predilection for this particular?
Ma'am, actually, axial spondyloarthritis or ankylosing spondylosis is usually more commonly present in young males. Ma'am?
And how?
Ma'am, am I audible to you?
Yes. Apart from the usual medication, how will you do follow-up in such cases?
Ma'am, I could not hear you. Ma'am, can you repeat again? Voice is not coming clear.
Hello?
Ma'am?
Hello?
Yes, ma'am. You're audible now. Yes, ma'am.
Yes.
Ma'am, I can hear
What
you
do
now.
you think? What is the cause of this? What is the cause of raised IOP in your case? In this?
Ma'am?
IOP. Why the IOP?
What is the cause
okay,
of
ma'am.
raised
Okay,
IOP?
ma'am. Yes, ma'am. Understood.
Yes,
Yes, ma'am. Yes, ma'am. Understood. Okay, ma'am. Ma'am, my patient had reported of giving us history of similar episodes in the past as well. In the last 6 months, she has been having these episodes for which she did not seek any medical attention. So probably the IOP was raised for a long period of time, which has contributed to optic nerve compression and glaucomatous optic atrophy.
To save the other eye vision, what do you recommend?
May I request the other panelists to please mute their mics so that we don't have a disturbance.
Dr. Sumit, you can use the master control to mute anybody else. Hello?
Yeah, I understand, ma'am.
Ma'am, should I repeat my answer again?
Yes. Yes.
Okay, ma'am. Ma'am, my patient had given similar history in the past since 6 months actually, for which she did not seek any medical attention. So probably the rise in IOP was prolonged for a long period of time. It was there for a long time, which was left unattended. So probably this has led to the optic nerve compression and glaucomatous optic atrophy.
So what are the usual causes of loss of vision in such cases?
Okay, ma'am. In anterior uveitis.
Yes. In this type of cases.
Okay, ma'am. There can be, there can be complicated cataract also. There can be, ma'am, secondary glaucoma can be a cause. Then cystoid macular edema. Those 3 are the main causes of loss of vision in a case of anterior uveitis.
So if the patient is not responding with the topical steroids, then how will you manage it?
Ma'am, if she's not responding to ma'am, steroids.
Topical steroids.
Okay, ma'am. Ma'am, oral steroids can also be given, but
if suppose the patient is not intolerant to oral steroid, how will you manage the case? Patient cannot take oral steroid.
ma'am, in such cases, ma'am, newer immunomodulators can be tried.
Yes, yes, very good. Okay.
We can
Thank you.
move on to the next participant now. The next is Dr. Renu Punia. Is Dr. Renu here?
Dr. Renu Punia.
Dr. Renu Punia, is she there? She is not there. Then Dr. Bhavna Chawla. Dr. Bhavna Chawla. Is Dr. Bhavna here?
Actually,
No.
this is becoming quite painful because then they later on land up and say, so let us do 11 candidates in the first session, whoever they may be. Hai na, Dr. Smith?
Yeah.
Yes.
Dr. Manika Sharma. Dr. Manika Sharma. Dr. Manika is not there. Then Dr. Mishika Bhasin. Dr. Mishika is not there.
Dr. Monica, from which institution are these?
I think they're from, three of them were from NC Medical College, Panipat. And Dr. Mishika is from Santosh Medical College, Ghaziabad.
Hello, next.
We have Dr. Sumbul Fatima. Dr. Sumbul Fatima. No. Dr.
Hello,
Vaishnavi.
yes, sir. Hello,
Yeah.
yes, sir. Dr. Sumbul Fatima.
Please, Dr. Fatima, please, can you turn on your video as well as your presentation?
Yes, just 1 minute.
Your time will start the moment you share your screen and start talking.
Sir, it's just connecting.
No problem, no problem. We are waiting.
Sumit, how many 4 presentations have taken place?
Still now, yes, ma'am.
So we have 7 more to go. We have to stick to the timing. Okay,
But
thank
we
you.
have the ones who have not presented. So we have covered 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 we have covered.
Let us do 11 presentations because I know they will land up later. Yeah, because let's do 11. Okay, thank you.
Hello.
Yeah. Dr. Fatima, please, can you start with your presentation?
So is my topic visible on the screen? Toxic
Yes.
amblyopia?
Yes, it is.
Yes.
Okay, good evening, everyone. My name is Dr. Sumbul Fatima. I am first year PG junior resident from Santosh Medical College and Hospital, Ghaziabad. My topic is toxic amblyopia. So amblyopia, as we know, it is unilateral or bilateral decrease in the best corrected visual acuity caused by vision deprivation or abnormal binocular interaction for which there is no identifiable pathology of the eye or visual pathway. But here in case of toxic amblyopia, we know that the cause is because of the toxins. So basically this name toxic amblyopia is a misnomer. So now it is known as the toxic optic neuropathies. The etopathogenesis of toxic optic neuropathies is that basically in the cells of the body, in the mitochondria, oxidative phosphorylation takes place in which there is electron transfer to oxygen and there is ATP production. Vitamins such as B12 and folic acid are needed in the process, and there are a few toxic agents like cyanide or formate which block the electron transport chain and thus resulting in decrease in the ATP production by the mitochondria. By decreased ATP production, in various cells of the there are compensatory mechanisms to cope with this metabolic stress, which can in case of muscles, and all, where there is increased production of mitochondria. But in case of neurons, especially the neurons which are thin, low, and unmyelinated, such as the papillomacular bundle, they are at greater disadvantage and are more prone to damage because of these conditions. And so their damage occurs. Many nutritional, toxic, and hereditary neuropathies produce a very similar clinical picture because they are common pathways in which the vitamins work and in which many of these toxins interact. The clinical features because of the damage of these neurons is insidious onset of painless bilateral central blurring of vision, and there is abnormal color vision. In case of any such presentation, inquiry should be made about the potential causative medications the patient is taking, environmental toxin exposure, and the dietary vegan diet if the patient is a vegetarian. A family history of optic neuropathy should be excluded. Peripheral neurological symptoms such as sensory loss, gait disturbances should be, which raise a suspicion of peripheral neuropathy, should be excluded. Then signs of toxic amblyopia is there is decrease in visual acuity, and on fundus examination we'll see pallor in the disc, which is often temporal. There will be splinter hemorrhage on the disc, and there is minimal edema. The pupils are normal in the beginning, but may respond weakly in the severe cases. These are the pictures, which are the fundus pictures, showing a slight pallor at the temporal side. Then what are the investigations we do? We do the color vision testing. The color vision is disproportionate in reduction compared to the reduction in the visual acuity. Red desaturation is likely to be present. Ishara chart, we use the Ishara chart to test the color vision. Then the visual field defects. It is bilateral, symmetrical, and centrocecal scotomas are present. Then OCT will see peripapillary RNFL thickening, which will help to exclude macular pathology. Fundus autofluorescence to exclude macular changes secondary to cone or cone rod dystrophy that present with color deficiency and central scotoma. Then blood test we do to rule out various deficiency of vitamins like B12, folate, B1, B2. Then even blood test to rule out any hereditary conditions which may lead to optic neuropathies. Visual evoked potentials. P100 amplitude is marked reduced, but with normal or near.
Dr. Fatima, your time is up, please. It's up, so I can ask the judges.
The presentation must be stopped right now. I may request the judges to please ask questions.
Please ask the questions now.
Hello, Dr. Fatima. That was a very excellent presentation. So I will ask a few questions. Can you please tell me how you differentiate? What are the differential diagnoses in a case of toxic amblyopia? A patient has come to you at your clinic, and you have to differentiate it from the other similar condition disc. What are the differential diagnoses?
Dr. Fatima, did you get the question? Dr. Fatima, you can unmute yourself.
Hello.
Yeah, you can please answer the question of the judges.
So first we'll see if there are, first we'll rule out various toxins which may be responsible for the condition, like the various toxins which cause optic neuropathies are ethyl alcohol, methyl alcohol, tobacco. Then we'll rule out drugs which cause such optic neuropathies like amiodarone, hydroxychloroquine, chloroquine, ethambutol.
Dr. Fatima, please switch on your camera while answering.
Dr. Fatima, can you switch on the camera while answering?
Such case.
Yes, sir, 1 minute.
Yes.
Yes, sir.
I request Dr. Divya also to ask a question or so, please, ma'am.
Hello.
Yeah.
Yes.
Hello. Yes, ma'am.
Differential diagnosis and such case.
Ma'am, differential diagnosis will be toxic, various conditions which cause the toxic optic neuropathies, and there are conditions which leads to nutritional deficiencies.
You didn't get my point.
Hello?
You are talking of other. I am asking you what is apart from toxic amblyopia, other
Ma'am,
causes
nutritional optic neuropathies and hereditary conditions which lead to optic neuropathies like Leber, Zaire, optic neuropathies. Then in nutrition, there is deficiency of vitamin B12, B6, folate, B1, and yes, ma'am, nutritional and hereditary optic neuropathies.
What is the
any other judges can ask question.
Dr. Divya, you can unmute yourself.
In India?
Hello.
Hello, ma'am.
Fatima, what are can you just classify the amblyopias, types of amblyopia? I mean, you have said toxic amblyopia. I just want to know what are the other types of, what is the classification of amblyopia?
No, ma'am, not right now.
Okay. We can move on to the next speaker then. And the next speaker would be Dr. Vaishnavi Singh. Dr. Vaishnavi Singh is there.
While Dr. Vaishnavi is doing, Mr. Amit from ACOIN, are you there? Mr. Amit or anybody from ACOIN? Okay, no. We can. I was asking them to make a WhatsApp group specially for judges and Dr. Samantha and me so that scores can be shared there.
Yeah.
Okay, thank you. We can carry on.
Dr. Vaishnavi is not there. Dr. Nupur Bhatnagar. Dr. Nupur Bhatnagar. No. Dr. Aditi Sinha. Dr. Aditi Sinha. Dr. Poonam Juneja.
Yes, sir. Dr. Aditi Sinha here, sir.
Dr. Aditi.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
You start with your presentation.
Yes, sir. Sir, is my screen visible, sir?
Yes.
Hello. Yes, sir. So I'll be starting with my presentation, ocular sarcoidosis.
Your presentation is not yet visible.
Okay, sir. 1 second. Sir, is my screen visible now?
Yeah.
Okay. Okay, good evening, everyone. I'll be starting my presentation that is on ocular sarcoidosis. I'm JR1 from Santosh Medical College. So first we'll know about sarcoidosis. Sarcoidosis is a chronic multisystem granulomatous disease in which there is an exaggerated cellular immune response either to self or non-self antigen in a genetically predisposed individual. It is basically, we diagnose sarcoidosis by three things, that is typical clinical features, a positive chest radiology and a positive biopsy mainly to exclude other common infections like Mycobacterium tuberculosis and fungal infections. It is a unique disease because it shares similarities with tuberculosis, all in clinical, radiological and histopathological fields. It was first described by dermatologist Jonathan Hutchinson, who described it as a Mortimer's malady. Basically, Jonathan Hutchinson was a dermatologist who first described this disease, and he named it after the first patient as Mortimer's malady. Later on, sarcoid term was coined by Caesar Boeck because it resembles a sarcoma on histology. Later on, first ocular manifestation, that is of uveitis, was seen by Herford. Earlier reports shows basically initially it was believed that this disease is of the West, that is of the developed world, and it was rare in developing world because it was overshadowed by tuberculosis. In recent reports, it is shown to be because of increased awareness. Now it is known to be a prevalent disease even in the developing world because of availability of higher modalities of investigations. So routinely it is considered in the differential diagnosis of respiratory and non-respiratory diseases, including ocular problems. Coming to etiology, various etiology are said to be there for this disease. Major include infections. Most studied among them are Mycobacterium tuberculosis and other mycobacteria. In space clustering, there are certain population shows high sarcoid prevalence, like people living in higher latitudes, and in people having vitamin D deficiencies, and certain ethnicities like African American populations. Even environmental and occupational exposure to things like aerosol, beryllium, silica shows higher prevalence of this disease. Coming to the clinical features, it shows two peaks of incidence, first in the 20 to 30 years and then to the 50 to 60 years. Higher incidence of ocular involvement is seen in case of women. Ocular involvement in systemic sarcoid is about 12 to 76%, and ocular involvement as a presenting symptom is in 30 to 40%. So coming to the ocular involvement, extraocular involvement includes, extraocular involvement includes mass-related like proptosis and diplopia, bilateral lacrimal gland enlargement, preseptal swelling. Intraocular includes dry eye, which is very common, known as keratoconjunctivitis sicca. Conjunctival granulomas, non-granulomatous uveitis, granulomatous uveitis, iris nodules, and scleral nodules. Granulomas in the angle or peripheral iris is known as Berlin's nodule, and 10-shaped posterior synechiae on gonioscopy can also be seen. Rarely corneal opacities like posterior stromal or at the level of endothelium can be seen, and sometimes band-shaped keratopathy can be seen. Posterior segment involvement includes vitritis, snowball exudates, candle wax retinal vasculitis when the blood vessels are involved. Then choroidal granulomas can be seen. These are well demarcated orangish red in color. It can be solitary or multiple, can be unilateral or bilateral. Then irregular choroidal depigmentation can be seen, and retinal and pre-retinal granulomas can also be seen. Ocular nerve involvement includes disc edema and optic nerve granuloma, and rarely neuroretinitis, optic atrophy, and other features can be seen. Multimodal imaging in ocular sarcoidosis. Fundus photography is important for documentation and objective future comparisons. Fluorescein angiography is important. Iodocyanin green angiography, optical coherence tomography, that is OCT, and optical coherence tomography angiography, that is OCT-A, can be done. So these are some of the pictures showing fluorescent angiography.
Your time.
Yes, sir. Okay, sir.
Yeah.
Yes, sir.
Ma'am, can you unmute yourself?
Aditi?
Yes, ma'am.
Am I audible?
Yes, ma'am. You're audible.
I just want to know what are the typical features in the X-ray in the case of sarcoidosis?
Ma'am, X-rays, mostly chest X-rays will show complexes in case of sarcoidosis, and it is very similar to findings seen in tuberculosis. And for that, we need to basically, ma'am, do biopsies to confirm whether it is a sarcoid case or any other, to rule out tuberculosis and other cases.
So, how will you differentiate with tuberculosis? Only on the biopsy. Other than there's no
Dr. Sana, there are two devices. Can you just close one? There is an echo coming. There's somebody else also there.
No,
I'm hearing my voice. I believe there are two devices where you are sitting.
Somebody has logged two devices.
Ma'am, I'm just logged in through my laptop.
Now it is okay. Now it is okay. Now I'm still able to get my voice. Doctor Sinha, it is coming from your side.
Hello, Dr. Aditi.
Yes, ma'am.
Dr. Aditi, can you hear me?
Yes, ma'am. Yes, ma'am. I can hear you.
So it's a very good presentation. Beautiful slides. Very beautiful slides.
Thank you so much, ma'am. Thank you, ma'am.
Ma'am, you're not. Doctor, please, you're not audible. Dr. Sinha, you have two devices. आपने एक जगह पे दो devices से connect किया.
I'm sorry, sir. I'm trying to find out the issue. Yeah, but I'm just logged in through my laptop, sir.
Or there is somebody else.
They ask acquaintance to stop the devices. Okay, Aditi,
I'm sorry, ma'am. Can you just repeat once? I couldn't hear.
Suppose if patient has come to you with a nodule and the eyelid, what are the diagnosis?
Ma'am, nodule in the eyelid, we can either see whether it's an inflammatory nodule or a non-inflammatory nodule, whether there are signs of inflammation present or not. If signs of inflammation are present, we can consider it as a DD of a style or a hordeolum. In case there the signs of inflammation are absent. Non-inflammatory, ma'am. First differential diagnosis, a very common is chalazion. Granuloma, a very common granulomatous disorder, chalazion. Ma'am, that will be the major diagnosis.
Got it.
We go on to the next speaker.
Okay, sir.
Sarcoid nodule.
Yes, ma'am.
What are the other lesions?
Hello.
Yes.
Yes, ma'am.
Similar type of nodular presentation. Systemic
there is an echo coming there. Absolutely not understandable.
Mr. Sunil, can we do something about this echo?
Sir, somebody's got two devices. See, there is an echo coming. I can hear my voice. It is coming from Dr.
one device.
Either there are two participants sitting in one room or somebody is logged in from.
Are there two people sitting in one room or there are two devices? Dr. Sinha, do you have somebody?
No, sir, it's just me and there's just my laptop. I don't know.
It could be somebody else. It doesn't have to be her.
One else.
Very disturbing.
May I request you to mute everyone except the judges, and Dr. Sumit and the presenter.
See, now it is gone. Sinha is muted.
Okay, I think we can go to next speaker.
Dr. Chandana ma'am and Dr. Divya, I have made a WhatsApp group for both of you, Dr. Sapan Samantha, me and Dr. Sumit, in which the marks for this session can be posted afterwards. Thank you so much. It will be secret for us. Thank you.
Okay, ma'am. Thank you so much.
Thank you.
Poonam Juneja, is she there? Dr. Poonam, Dr. Pulkit Sharma. Dr. Pulkit Sharma? No. Dr. Madhu Kumari? Dr. Madhu Kumari? Is it Dr. Acid? 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 I don't know.
Yes, there is a name of Dr. Acid, yes.
Okay, that's quite sweet. Okay, Dr. Acid. Dr. Acid is there? No. Then Dr. Gagandeep Kaur? Dr. Gagandeep Kaur, Dr. Harmanjot Singh.
Hello.
Yeah,
Hello.
please.
Sir, may I join Dr. Asik Dolakia?
Yeah, Dr. Asik, please, we were waiting for you.
Please, may I know your name? Is it a Sanskrit name or is it, as we know, ACID? What is your name?
It is ACID, ma'am.
What does it mean? Is it a different language
does
or
it
is
have
it English
another meaning
only?
in some other language?
No, it is in English, ma'am.
Okay, good. Okay, sorry. Great.
That's great.
Yeah.
Okay, please. You can start with the presentation.
আমার হয়ে গেছে হয়ে গেছে ভালোই হয়েছে
You can start with your presentation, Dr. Asik.
Yeah, yes, sir, just a minute, sir, please.
Yes.
There's somebody called Dr. Mishika. Is she a part of the
I
list,
think
Dr.
he was.
Sumit?
Yes, he was.
She's just sent a message. So, Dr. Mishika, you can present after this. There's no issue.
Is
Okay?
this session is over?
No, sir, no.
Is this session is over?
No, sir, it's not over.
Dr.
There's a lot of
Sumit?
people missing. We have to do 11 in this session, sir, because
How
they will
many
come back
papers are
later.
still left?
Sir, we have done 6 or 7,
Yes.
Dr. Sumit.
So,
Six. So far,
6.
so
So
may we wait?
No, we can't wait. We can't wait for anyone.
No, sir, we cannot
Only
wait.
6.
They are sending lots. We are doing 11, whoever is there, whichever candidates. We're writing down the names, sir. Please start, Dr. Acid.
Ma'am, I'm actually unable to share my screen at the moment.
Dr.
Okay.
Mishika, are you able to share?
Dr. Mishika, can you?
Ma'am, I'm trying for the same.
Okay, you try. Dr. Mishika, please start. Then Dr. Acid can do. Okay, good. We can see your screen.
Mishika,
Carry on.
We can see your screen.
Dr. Sumit, timing, please. Thank you.
Mishika.
Good evening, everyone. I am presenting on the topic evaluation of a case of ocular trauma. I am PG1 from Santosh Medical College, Ghaziabad. Initial assessment. On initial assessment, the patient's consciousness level is assessed. It is important to establish mechanism of injury, including blunt or penetrating, velocity of impact or projectile, point of impact, material, and any other details relevant to overall energy of impact. History taking. We need to ask following questions to the patient. Was the event witnessed? Was the patient wearing protective eyewear, if applicable? Were any visual changes noted soon after the trauma? Does the patient use any anticoagulant medications, suggesting that a bleed may have formed in the anterior chamber? Any ocular history or previous ocular surgeries, including implants, scleral buckling, filtration implants, previous wounds in the eye? Any other personal medical history or pertinent family history? And is the patient tetanus vaccination up to date? Symptoms. Introduction. General and comprehensive evaluation of an injured patient and an injured eye is very important to save life and sight. Appropriate analgesia, sedation, and protection of open globe from further injury are an important part of the evaluation. Antiemetics should be administered to avoid Valsalva maneuver if the patient has nausea or vomiting, to prevent possible extrusion of intraocular contents. Systemic evaluation. Vital signs should be monitored continuously. Entrapment of an intraocular muscle may lead to life-threatening bradycardia, particularly in children. Therefore, heart rate should be monitored. Brief assessment of other bony and soft tissue injuries must be performed. Once the patient is found to be stable, ophthalmic evaluation can be proceeded safely. Initial ocular examination. The ophthalmologist should have a high index of suspicion for damage to other parts of the eye when traumatic cataract and or glaucoma are present. Concern for damage to the anterior chamber angle structures, zonular fibers, corneal endothelium, vitreous, and retina should be high. Attention should be paid to the integrity of the lens capsule. Visual acuity. Important predictor for the ocular trauma score. Vision should be tested with correction and pinhole using Snellen's chart. If vision is lower than this, finger counting may be recorded. If this is not possible, hand motion or light perception may be recorded. Pupillary reaction. Relative afferent pupillary defect is an important negative prognostic factor for affected eye. This finding should raise suspicion for optic nerve damage, avulsion, and compartment syndrome if other signs are present. Intraocular pressure. Intraocular pressure may be high, low, or normal following injury. Low intraocular pressure or hypotonia should raise caution during exam for ruptured globe, and care should be taken to protect the eye from extrusion of contents.
The eye should be shielded when not under examination. Leakage of lens protein from a non-contact lens capsule into the aqueous and/or vitreous, as well as non-inert intraocular foreign body, can elevate intraocular pressure as a result of inflammation. Presence of blood in the anterior chamber, known as hypema, can decrease outflow facility of the trabecular meshwork and elevate IOP. Cyclodialysis cleft, ruptured globe, or retinal detachment can cause decreased intraocular pressure. Occult bleeding within the orbit posterior, the globe, can cause orbital compartment syndrome and elevated IOP. Tight eyelids, difficulty opening the eyelids, proptosis, periorbital edema, and an RAPD are classic signs of orbital compartment syndrome, which is a true ocular emergency. This is a picture showing the collection of the blood in the anterior chamber, known as hypema. Motility. It is important to assess ocular motility when there are chances of direct or indirect damage to extraocular muscles. Extraocular muscle entrapment must be ruled out. Field testing. Central field can be evaluated by the Amsler grid and peripheral field by confrontation method. However, this is at the best a gross evaluation and should be followed up by automated perimetry when possible or available. Slit lamp examination. Corneal endothelial.
The judges can ask questions. Judges, please.
May I request the judges to please ask questions?
You can stop
Mishika?
sharing.
Yes, ma'am.
Yeah.
Can you hear
Am
me?
I audible?
Yes, ma'am.
Okay. So I just wanted to ask, how will you check for the EOM entrapment? How will you rule out it?
For the
Stop the presentation.
You can stop your presentation.
Extraocular muscles का entrapment को आप कैसे rule out करेंगे? Whether it is entrapped or not?
Ma'am, we will check the extraocular movements of the eye in various quadrants of the patient.
Okay. And you said one thing in your presentation. Okay, tell me the classification of ocular injuries.
Ma'am, it is basically it depends. It's the depends on the impact, that it may be a close injury or it may be an open injury, and then it may be depend upon the type of the trauma. For example, the blunt injury or the penetrating injury. And it depends upon the form, there is alkali injuries, chemical injuries, the form of the injury, basically.
Okay. What are the... Okay, ma'am. Ma'am, over to you, ma'am.
I have a question to you. You talked about orbital compartmental syndrome. What is that? What is that? And how will you manage such case? What is the cause of this orbital compartmental syndrome and how you manage such case?
Dr. Mishika?
Dr.
Hello?
Mishika, I have one question. You are a first-year guy, that's why it may be difficult for you. I just want to ask you, whenever any patient with any ocular injury will report to the emergency, what would be your very first procedure? Whenever any patient with any ocular injury report to the emergency, what would be the very first procedure?
So basically, we will start with assessing the consciousness level of the patient and then history taking. We need to see the type of injury, the cause of the injury, and the time of the injury.
It's okay.
Don't you like to have a police case? Don't you like to have a police case? That is the foremost thing in India. Whenever you come across any injury in the OPD or in the casualty, first visit, first is the police case. You must have to do police case. Then you
Yes,
can
sir.
proceed to do whatever you like to see. Thank you.
Yes, sir.
Proceed.
Thank you.
Can we have Dr. Acid next presentation, please? Dr. Acid, are you there?
Yes,
Bob.
ma'am.
Professor Manisha.
Yes, sir.
We have our next session from we have our next
No, sir, we are not completing the number
session
of
from
candidates.
8 p.m.
No, sir, we will not be able to complete
Okay,
number of candidates.
then because the next group of judges, they are waiting and they are asking when the next session. I told them at 8 p.m. So I think the best would be 11, 11, 11. Let 5, 6, 7 absentees leave it. Then we have to stick
Dr.
to the
Sumit, how
time
many
and
have we
session.
done? Seven? How many?
Seven.
Okay, sir.
Seven.
Then we'll take a break.
Now, how many were there in this particular session, Professor
Sir,
Sajid?
there were 11. Sir, we will let one more candidate finish. She's just starting, Dr. Acid. So there will be 8 in
Yes.
this group then.
Please,
And I have made a WhatsApp group with you, me, and the judges. And
take
Dr.
one
Sumit.
more candidate. Then we will have some pause. Then we'll start the second session.
All right, sir. Done, sir.
Because I will also send the number. That's why 3 will be judges, no problem. Then we
So the
can.
problem is
So
that a lot of
we will have to
candidates are
start the
missing.
second session.
I hope they don't start land. Okay,
Yes,
sir.
every time, lot of candidates are absent. And tomorrow they will just send the message that they are traveling, got exam, they are on emergency call. So many excuses. So many excuses. Right now they are in a movie or they are somewhere else. But what we have to stick our time and we will call on the first 11 like that. Like that. Am I right, Professor Sajid? Thank you.
Thank you, sir. Dr. Acid.
Because next time international judge is there.
Got it, sir.
Please start, Dr. Acid.
Hello. Hello.
Yeah. You can start, Dr. Acid.
Sir, is my screen visible?
Yes, it is. You can use a full screen. Are you presenting from your phone?
Yes, sir.
Can you put in a full screen, please?
Yes, sir. Just a minute, please.
Dr. Sumit, the time starts now.
Is it visible, sir?
Make it horizontal and make it on a full screen, auto rotation mode.
Yes, just a minute, ma'am, please.
Yes.
Is it visible, ma'am? Hello?
Yes, visible.
Yes, it is.
May I start, ma'am?
Yes.
Good evening, everyone.
Yeah, I've started.
Good evening, everyone. Good evening, judges. I am presenting a case report on a case of tuberculous osteomyelitis of the skull base, which presented to our outpatient department as lateral rectus palsy. This is the case of a 22-year-old woman who presented on the 2nd of February 23 with only few complaints of left eye restriction of the eye movements, diplopia in the same eye, and headache since 4 to 5 days. She had a past medical history of tuberculosis for which she was on isoniazid, rifampicin, pyrazinamide, and ethambutol for the past 4 months, and the patient had no significant family history. Her general examination, the vitals were within normal limits. In the right eye, her vision was 6/6, left eye it was 6/9. In the right eye, all her movements of the extraocular muscles were full and free, while in the left eye, there was a restriction in the movement in the temporal gaze. Also, there was uniocular diplopia present in the left eye in all of the left lateral gazes. Slit lamp examination and both fundus examination were within normal limits. This is the patient exhibiting lateral rectus palsy in the left eye. At that point, we had reached several differential diagnoses like tuberculoma, meningioma, craniopharyngioma. She had undergone several investigations like complete blood count, CSF adenosine deaminase, ESR, RFT, RBS, LFT, and routine urine. We had also made her undergo MRI of the brain and the orbit. Her CBC, routine urine, and ECG reports were normal, while her adenosine deaminase, which signifies the presence of tuberculous bacteria in the CSF, was raised. It was 17 units per liter. ESR was also raised. There were also abnormalities in KFT and LFT. Her investigation of MRI brain showed that there was altered signal intensity in the body of the sphenoid on the left side, left petricifex and clivus on the left side, with associated dural thickening in the left prepontine region, compressing the cistern segment of the left sixth nerve, suggesting some infective etiology. MRI of the orbit shows atrophy of the left lateral rectus muscle and compression of the sixth nerve. These are the MRI images of both the brain and the orbit. She had also gone left cervical lymph node biopsy, and the histopathological examination showed that there were inflammatory cells on the background of RBCs, while no granuloma was seen. There was a left cervical lymph node suppurative lesion. Considering all the above investigations, we came to a diagnosis of tuberculous osteomyelitis of the skull base with lateral rectus palsy. The patient was on the treatment of cefalexin, hydrocortisone, dexmedetomidine, tramadol, mannitol injection, while tablets of levoflox, dexamethasone, pyridoxine, calcitriol, and aceclofenac. The patient's condition improved only 5 days after she received treatment. And here, as we can see in the picture, she is able to see on the left side quite comfortably. Tuberculous osteomyelitis is an uncommon form of extrapulmonary tuberculosis. It accounts for 10% of extrapulmonary TB and 1 to 2% of all cases of TB. Skull base osteomyelitis is broadly classified as typical and atypical. Typical skull-based osteomyelitis is related mostly to infections of the temporal bone, especially necrotizing otitis externa.
Time is up,
While
Dr. Ashit, please. Your time is up.
Madam, judges, may we please ask you to ask questions now?
Hello, Dr. Asid.
Yes, good evening, ma'am.
Yes, good evening. Can you please show us the MRI or CT, whatever you have?
Yes, ma'am, just a minute, please.
We can't, it is not visible actually. What you want to show us, please show us the picture where
yes,
you actually are highlighting. Please highlight that area where what type of lesion is seen in a case of tuberculous osteomyelitis.
Yes, ma'am, just a minute, please.
Radiological. I'm asking about radiological.
Yes, ma'am, radiologically, ma'am, there was...
You said you have done MRI, no?
Yes, ma'am, MRI of the brain and orbit, ma'am.
So, what do you think? MRI? Is it MRI or CT? Which will be better to the...
Hello? Yes, ma'am. Ma'am, actually, according to several reports, a CT examination is a much preferred modality. But in this case, since we were also wanting to see the orbit and the extraocular muscles and the condition of the sixth abducens nerve, we in this case chose to do MRI.
On what basis you diagnose this case as a tuberculous osteomyelitis? Point number 1, 2, 3. Why you diagnose this case as a case of tuberculous osteomyelitis?
Ma'am, basically, it was helpful to know the fact that the patient was already suffering from tuberculosis.
Yes.
We were also suspecting tuberculoma. But after her MRI reports were received and there was a histopathological report done of the cervical lymph node, and it was seen that there were certain infective cells seen in the lymph node. So it led us to think towards an infective etiology of the skull base, and that led us to consider tuberculous osteomyelitis.
No tuberculous granulomatous lesion was found, no?
No, ma'am. Infective etiology was found. There was no granuloma found in the cervical lymph node, ma'am.
Yes. But you are supposed to get that, no? What was the Mantu report and what was the ESR?
Ma'am, the ESR was raised. It was 30. Yes, ma'am. The ESR was 30 mm per hour. And ma'am, the patient was on already anti-tuberculous drugs since the last 4 months, ma'am.
Okay. What are the various presentation of orbital tuberculosis?
Ma'am, in orbital tuberculosis, the patient presents with several very common conditions like redness and watering. There might be pain in the eyes. There might be limitations of the eye movements.
In orbital tuberculosis, orbit, not ocular, I'm talking. Orbital tuberculosis you are talking, na? What are the other features that patient can present with?
Ma'am, in this tuberculous osteomyelitis of the skull base, the other features can be related to any CNS symptoms the patient can come with. Like in our case, there was lateral rectus palsy. There can be CNS
How the
symptoms.
orbit, can you tell me how the orbit is involved in tuberculosis? What is the mode of infection of involvement of orbit?
Ma'am, in our case, actually, the tuberculosis is of the skull base, but since there is compression of the sixth nerve, there was a palsy in the lateral rectus.
No, I'm not asking that. How it spreads?
Okay.
In the orbit, how it has come?
Okay, ma'am, through lymph and blood, mostly because it's extrapulmonary, it can spread through blood and lymph, ma'am.
Okay. Okay, thank you.
Okay, Dr. Acid, just one thing I need to ask.
Yes, ma'am. Yes, ma'am.
You have mentioned that the patient has a unilateral diplopia, right?
Yes, ma'am, in the left eye, ma'am.
Okay. So, how will you differentiate unilateral and bilateral diplopia?
Ma'am, we will do it individually for both the eyes. If diplopia is present in a single eye or it is present in both the eyes together.
Yeah. So, in your patient, it is in one eye.
Yes, ma'am. It is in left eye only, ma'am.
No, but you have checked whether the patient has unilateral diplopia or bilateral binocular diplopia. Uniocular or a binocular diplopia?
Yes, ma'am. We had checked in both eyes separately, and we.
Listen, first, it's uniocular diplopia or a binocular diplopia.
Ma'am, it is uniocular diplopia in the left eye, ma'am.
So, do you think when the nerves and the muscles are involved, then there is a uniocular diplopia or a binocular diplopia? What are the causes of uniocular diplopia and the binocular diplopia?
Sorry, I'll not have to, I'll have to move forward because there are many waiting. So an interesting discussion was going on. We'll move on to the next speaker, please, now. Thank you, Dr. Esit, and thank you, Dr. Divya, for your questions also. So we'll go on to the next speaker. When Dr. Kritika had joined, I think we'll allow we'll allow Dr. Kritika to present, and then we can take a break.
Okay.
Thank you,
and
sir.
Judges, thank you so much for taking so much interest and actually teaching them and stimulating them to think. Thank you so much, both.
Great.
Dr. Chandana ma'am and Dr. Divya.
I didn't want to stop it, but I had to because
yes.
the time is for everyone.
Time. Okay.
Yeah. So we'll go to the next. Dr. Kritika, have you joined?
Yes, sir.
Yeah, please present your case. No.
Yes, sir.
You're visible and audible, and you can start.
So, are the slides visible?
Absolutely, that's what I said.
Okay, sir. So I can start.
Please do.
A very warm good evening to everyone. Firstly, I would like to thank the organizers for giving me the wonderful opportunity. I, Dr. Kritika, PG resident, is going to present my case on topic vascular occlusion in a patient with posteriorly dislocated double IOL. Firstly, retinal vein occlusion has an incidence of 0.6 to 1.1%, and age and uncontrolled hypertension are the most important risk factors for retinal vein occlusion. Retinal vein occlusion following direct trauma or foreign body in posterior segment is an unusual finding. And posterior capsular rupture is one of the most common complications following cataract surgery. IOL implantation following intraoperative posterior capsule rupture has an increased risk of posterior IOL dislocation. I present in front of you a case of a 71-year-old male who presented to our OPD with complaints of diminution of vision right eye for 2 weeks, which was gradual and painless in nature. Patient underwent cataract surgery right eye 2 weeks back, following which there was no visual improvement on first post-operative day. Patient underwent a second surgery for the same eye. After 4 days, there was no visual gain. The patient had no history of trauma to head post-operatively. On ocular examination, on right eye examination, the best corrected visual acuity was 20/200 and the IOP was 13 mmHg. Cornea shows edema, decimate membrane folds, arcus senilis, and the interior chamber showed vitreous strands superiorly at iris margin, which were not touching the endothelium. And the lens showed there was a dislocated single piece IOL, which was noted in the interior vitreous with a large posterior capsular defect. And on fundus examination, the CD ratio was 0.3:1. Posterior vitreous detachment was present. FR was dull. IOL resting over inferior retina was seen, and intraretinal hemorrhage along the inferotemporal arcade with sclerosed vessels was present. And the left eye examination showed normal findings. This is the photograph showing the slit lamp examination of the same patient, which shows out of the bag dislocated single piece IOL with one haptic which is stick in the iris tissue as shown in the diagram, and the other haptic in the interior vitreous with a large posterior capsular defect. As the management includes investigations and treatment, the first investigation which we did was fundus imaging of the right eye, which showed the black arrow which shows the IOL in the interior vitreous, and the another IOL which is resting over the inferior retina shown with the blue arrow. On fluorescein angiography, there was delayed filling of inferotemporal arcade and blocked fluorescence due to intraretinal hemorrhages. On SD-OCT, we can show there is sparing of the fovea and there is no macular edema. The plan of the treatment for this patient was the patient was referred for pars plana vitrectomy with IOL explant to higher center followed by secondary IOL or their optical correction. IOL explant should precede placement of which can be planned later. IOL dislocation has an incidence of 0.2 to 3%. It may cause several complications such as vitreous hemorrhage, retinal tears, retinal detachment, bullous keratopathy, cystoid macular edema, and secondary glaucoma. This case highlights the need for the urgent removal of a posteriorly dislocated mobile IOL, which should precede the placement of secondary IOL to avoid ocular complications. The hypothesis of my case is, as posterior vitreous detachment was evident clinically, presence of liquefied vitreous can allow the IOL to freely graze over the retina and cause a direct injury to the retinal vessels. Vascular occlusion in this patient has developed most likely due to direct injury to the retinal vein, which is caused by mobile IOL. Thank you.
Excellent time, and I'll ask.
Thank you. Thank you, Dr. Kritika.
What is your take-home message? What message you want to give us?
Ma'am, that if there is any posterior capsular rupture and we can see that the IOL has gone to the posterior chamber, we should immediately operate it and we should remove that IOL. We should not keep it as it is, as it can cause retinal vein occlusion.
That's all.
Yes, ma'am.
That's all.
Nothing more.
What else can happen?
What are the complications of posterior dislocation of IOL? Only retinal vein occlusion, nothing more.
Sir, it can cause occlusion. There will be
apart from,
sir, there can be
renal
retinal detachment can occur.
Yes. Yes.
Tractional retinal detachment can occur.
But if there is corneal edema and retina surgeon is not available, what will you do?
Sorry, ma'am?
In the immediate OT, when you are in the OT, retina surgeon is not available, then what will you do?
Ma'am, if the retinal surgeon is not available, then?
What will you do? You can't remove the thing immediately, no?
Yes, ma'am.
So how will you manage in such cases?
What would be your line of management if the retina surgeon is not available offhand? He's not there in the OT, and you'll have to wait for some period. What will be your line of management?
So we will leave it as it is and then
How long? How long you can wait? How long?
how long we can,
No. Okay. 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 That's okay.
So we have, ma'am, can we take a break right now or?
I think they are end of the session. I am not
End of the session. Thank you so much to our absolutely wonderful, wonderful judges, Dr. Chandana Chakrabarti ma'am,
Thank
Dr.
you.
Divya
Thank
Verma,
you.
Thank you, ma'am.
our moderator,
you,
Dr.
Dr.
Sumit, and ma'am, like they write in movies, na, above all, Dr. Sapan Samanta sir, and all the wonderful participants. They really have worked hard for this, and they are not from our institution, other places. Good to see. Thank you
Yes.
so much, ma'am. I created a WhatsApp group.
I have few message to give to this participant. Participants are there or not? One
Yes,
is that please do not put too much of text in your presentation. That is one. Next is that in each presentation, you should put references. You should put references from where you have taken that line. Okay. These are the two most important things lacking. One, please write very few text in the presentation. Don't make the slide too much crowded.
Yes. Ma'am, actually, they're writing paragraphs and sentences instead of just bullet points of 6 on each slide and all. They're very important. Thank you so much, madam. Ma'am, I've created a WhatsApp group with Dr. Sapan Samanta, both are judges, me and Dr. Sumit. The scores may please be posted there.
Okay, sure.
Thank you so much. Thank you so much for this wonderful.
Good
evening,
Dr.
Manish. Thank you. Next session at 8:30 p.m. Thank you. Thank you.
Hi, ma'am. Good evening, Dr. Urmil, ma'am. How are you?
Good
Dr.
evening.
Urmil,
Actually, my name is on the flyer, and after message Manta sir, I decided it was my duty to join. And many of these PGs were in touch with me in the initial part. So thank you, Dr. Manisha ma'am, for conducting it so very well, and the team, entire team, and really good presentation. Thank you, ma'am. Really wonderful job done, ma'am. बहुत अच्छा लगा और बहुत अच्छा RIO is rocking. RIO is rocking. That is more important. Chalo, great, ma'am. Good night.
Join at 8:30.
Yes, Dr. Sapan Sumanta sir. Next session 8:30. Thank you so much. Thank you. Bye bye.
Mr. Sunil, are you there, sir?
Hello.
Hello, Mr. Sunil. Mr. Sunil from Mentored. Anyone from Mentored?
We'll take a break until 8:30 now. We just finished first session.
We'll put it in the chat.
Yes, thank you.
Yeah.
Thank you.
ओके अब हमें शेयर
Hello. Hello. Good evening.
এসে গেছে।
Good evening, Dada.
Yeah, নমস্কার।
নমস্কার, কেমন আছেন? How are you?
ভালো আছি, ভালো আছি। এই জন্য জয়েন করেছো, এই জন্য ধন্যবাদ ধন্যবাদ। বাংলাদেশে খুব ভালোই হলো।
Thank you.
8:30 শুরু হবে, 8:30 একটু পরে। এই থেকে সৌমেশ এই চন্দনা চক্রবর্তী বলবেন জয়েন করুন।
Good evening. Dr. Monica, are you there? Dr.
Yes, ma'am. Good evening, ma'am.
Evening. We have started, sir. We have got the next candidates. Dr. Samantha, sir. Should we start?
Yes, just coming.
Sir, we have got 10 candidates for next session.
Yes.
So,
yes, now we are getting ready. Let us wait for here.
Dr. Lipi?
We have 4 judges.
Okay.
We have 4 judges. Right now, Professor beloved Dr. Mili Shakur has joined from Dhaka. He is the professor of ophthalmology, National Institute of Ophthalmology, Dhaka, Bangladesh. Professor Mili, here is with us Professor Manisha Roti, the coordinator. Professor Manisha Roti is the coordinator of this particular program. She is the second in command in Regional Institute of Ophthalmology, Rohtak, Haryana, Central India, and Northern India. She is looking after all this beautiful work, and she is very much interested with all this PGP program and other, and very much efficient. Lucky to have him. Dr. Professor Urmil Chawla, are you here now? Professor Urmil is not there.
Sir, our moderator for this session is Dr. Monica, and she will be noting the time.
Yes, now we are waiting for 2 more judges to join. Dr. Lipi Chakraborty from Madhya Pradesh, from Chandulal Chandrakar Medical College, Durg, Madhya Pradesh. He will join in this session, as well as Dr. Chandana Chakraborty will also join in this session. We are trying to get them, and then we'll start the session. Then we'll start.
Sir, I will hand over to Dr. Monica Daya. She is a senior resident with us, very hardworking. Yes. She's been making all the lists of the candidates. Dr. Monica, are you there?
Yes, ma'am, I'm here.
Madam, Professor Manisha Rati, you are the supreme boss. What you will direct, and we will follow. We will follow. Nothing. In this beautiful webinar, you have organized beautiful webinar. Hats off to you. It's really extraordinary. And that's why I am just trying to get Dr. Chandana Chakraborty. Why she has left?
Sir, she must be having dinner, I think.
No. Are join Kurun. No. Arekta session kore din. আরে এই সেশনটা করে দিন। এই সব এই বাংলাদেশ থেকে মিলি চক্র ওয়েট করছে, আপনি করে দিন প্লিজ, জয়েন করুন। ওকে, জয়েন করে যান, বলে দিচ্ছি। Professor Manisha, you are right. She is preparing the dinner because she has no time to prepare dinner just after coming from the hospital. However, I told her, now I am asking to leave me.
Yes, sir.
Everybody is so busy in their life.
We'll start. Dr. Monica will tell the rules. There are 5 categories for evaluation of 20 marks each. I have shared the sheet in the judges group. So I will hand over to Dr. Monica. Thank you, Madam. Dr. Millie, so much for being here. It is a pleasure to have you, and such a dedicated team. Sir, Dr. Sumit, Dr. Ruchi, and Dr. Monica have been working very hard on this. We are very excited always to work with Dr. Samantha.
Dr. Samantha Bolchi. Please join. Yes. Before Dr. Professor Millie, please extend your cordial invitation to Professor Manisha to your country.
We'll be very happy to have you. Very soon, near future. Okay.
Yeah, and at the same time, Professor Sumit Sajdev is there. She is also a beautiful professor here. She is organizing all these things. So please extend the cordial invitation from Bangladesh.
Yes.
Okay.
Sir, Dr. Ruchi is also here. Ruchi, are you there?
Dada just came to Bangladesh last week, and for us to have him in our conference, and I hope you will all will have get together in Bangladesh very soon.
Yes, ma'am. Very nice, ma'am.
Yeah, but now it's very summer is not a good time to.
Yes, ma'am.
Winter, okay.
Yes, ma'am. Ma'am, so I will hand over to Dr. Monica, our young and dynamic moderator, who will keep the time and who will cut off people at 4 minutes. And the judges will have 2 minutes for question answer to assess the students and encourage. It is, I'm very grateful for all of you being here. Thank you so much. Over to Monica.
Welcome, everybody. I think all the participants have joined. So the time given for your presentation is 4 minutes, and after that the time will be cut. And 2 minutes will be for the judges to ask questions. So I'd like to invite Dr. Bhavna Chawla to start her presentation and share the screen. Dr. Bhavna Chawla.
In the meantime, welcome.
Good evening.
Ophthalmology, Sandulal Chandkar Medical College, Durg, Madhya Pradesh, and our ever dynamic Dr. Chandana Chakraborty, also from Regional Institute of Ophthalmology, Kolkata. All these three beautiful judges are there, Dr. Mili, Dr. Chandana, and Dr. Lipi. Please carry on the program.
Good evening, everyone. Myself, Dr. Bhavna from first year. I'll be
Please share your screen, Bhavna.
Yes, ma'am. Ma'am, is it visible?
No, it's not visible.
मेरे टेलीफोन से कि तुम्हारे टेलीफोन से नहीं मेरे टेलीफोन तो ठीक ठाक नहीं है जरा बैठो ना क्या ठीक है ना
Bhavna, share your screen.
Yes, ma'am. Just give me 2 minutes, ma'am.
रूम देते हैं अंदर मिलेंगे तो टेलीफोन रख के जाना फिर लेके जाएंगे नहीं तो डिस्कनेक्ट हो जाएगा तुम्हारे टेलीफोन से ही लाइन आएंगे तुम जरा एक दफे रख के जाओ फिर आ जाओ बोल के तो मैं समझ से निकाल दूँ ठीक है ना बर्थडे है ना तो मेरे मालूम है मेरे टेलीफोन से तो नहीं होगा
Bhavna, if you are having problem, next participant can come.
Ma'am, just 2 seconds.
मेरे मालूम है अरे वो মৃত্যুঞ্জয় দেখ না ও এখন চলে যাবে ও টেলিফোন অফ করে দেবে আমাদের টেলিফোন হয় কি ও চলে যাবে এখনি ওর বার্থডে আছে বার্থডে পার্টি দেখ হয় কিনা দেখ হয় কিনা আমার তো মনে হবে না
Dr. Bhavna, are you there?
Next, Dr. Monica, start with the next person because we cannot wait that long. There are too many candidates and we have to be tuck on time. No?
Dr. Manika Sharma.
Next
Dr.
name.
Manika Sharma, are you there?
Hello.
Who is there? Please
Hello?
give your... Yes, who is this?
Ma'am, I'm Dr. Manika.
Okay, Dr. Manika, please
start
present.
your presentation.
Okay.
Ma'am,
And
is my
screen. When they start sharing screen and talking, Dr. Monica, time will be started.
Yes,
Thank
ma'am.
you
Yes,
so
ma'am.
much.
Sure.
So, ma'am, is my screen being shared? The PPT is PPT visible?
No.
Not yet.
Hats off to all the postgraduates for participating. I know you have problems with connectivity, time, emergencies, but वो assistant आ गए screen sharing के लिए करो. Now do it right away.
सुनो तुम्हारे नेक्स्ट होगा 9th को 9th
Can you wait, Dr. Malika? We'll start with the next one. आप इतनी देर में अपना कर लो. Synchronize. Dr. Monica,
Sure, ma'am.
next.
Sure, ma'am.
Next
Sure,
person.
ma'am.
Next is Dr. Nilakshi.
Dr. Nilakshi, are you there? Dr. Nilakshi?
Yes, ma'am, I'm here.
Okay, please start your presentation. Yeah.
Yes. Ma'am, am I audible and visible?
Perfect.
Yeah, you are audible and visible.
Yeah.
Start, please.
One second, ma'am. Just. Good evening, respected judges. I'm Dr. Nilakshi from AIMS Raebareli, and I would be talking about how to examine a patient with ocular trauma.
So ocular trauma is one of the leading causes of significant vision loss, and one must be familiar with the procedure of examination and recording data for medical legal purposes. So to begin with, we are supposed to identify and treat any life-threatening injuries, and that's the first and the foremost important thing. And next is to rule out any chemical injury or any open globe injuries, because these require urgent management. Furthermore, we need to classify our ocular traumas based on open globe and closed globe injury, and treat accordingly. A detailed history is crucial in once the patient is hemodynamically stable. We need to record the essential presenting complaints from the patient and the patient party based on the mechanism, the mode of onset, the point of impact, and the material with which the injury has occurred. A past history of the pre-injury visual acuity, the tetanus immunization plays an important role. One must also, after detailed history, one must also do vitals and systemic examination of other systems, and then move on to the ocular examination. A near and distant vision charting should be done, and pupillary reaction should be recorded, and look for dilated pupils and RAPD. For orbit, we need to rule out any kind of orbital fractures, and similar for the facial fractures. In the eyelid, one must look for periocular hematoma, lid lacerations, and ecchymosis and edema. In the eyeball, proptosis, enophthalmosis, and ocular motility dysfunction might be seen. Furthermore, a detailed slit lamp examination should be done in order to rule out conjunctival hemorrhage, chemosis, intraocular foreign bodies, any avulsion of the iris root, hyphema, pupillary peaking of the pupil, which is commonly seen in penetrating injury. In chemical burns, one should rule out conjunctivalization and vascularization, and we can also get phthisis bulbi in severe cases and entropion. Furthermore, the lens examination, we should look out for any cataract formation or rosette-shaped posterior subcapsular opacity, dislocations and subluxation. In the retina, one should rule out retinal tear, detachments and dialysis. And for optic nerve, one should look for traumatic optic neuropathy and optic nerve avulsion. Furthermore, one should assess the angle recession through gonioscopy, a Seidel test to detect any leaks. Intraocular pressure only after ruling out open globe injury should be done. Hess charting to map the eye movements, and field testing for through Amsler's bid or confrontation. Other investigations include CT scan, which is the gold standard for any intraocular foreign bodies.
Dr.
And
Nilakshi, time is up.
Yes, the presentation must be stopped immediately.
Yes,
judges,
time
time stop.
thank you.
Please stop the presentation. Thank you. Oh, thank you so much. Judges, may please ask.
Judges.
Your slides your slides are very good.
Thank you so much.
Good quality. Can you please tell me why you get enophthalmos in a case of eye injury?
Ma'am, enophthalmos can be there if there's any sort of like just after trauma, like if there's any orbital fractures or any such high impact, high velocity fractures, it can lead to enophthalmos.
Why? Why enophthalmos in orbital fracture? Why? You are in first year or second year?
I'm first year, first month.
First year, then it will be difficult for you, I think. What is the pupil shape in the case of dialysis?
The pupil is... I can't hear you, ma'am.
In a case of dialysis, what will be the shape of the pupil?
It should be peaked up. Peaked pupil sign?
No. Okay.
B-shaped pupil. B-shaped pupil. B-shaped pupil in iridodialysis, ma'am.
Yes. Any other judges are ready to, they can ask questions.
Nilakshi, do you have any idea on BETT classification?
There's a lot of disturbance.
Yeah, Nilakshi, can you hear me now?
Yes, ma'am.
Yeah. Do you have any idea on BETT classification? Birmingham Eye Terminology.
Yes, ma'am.
Yeah.
Yes, ma'am. It's basically divided into open globe and closed globe injuries. And furthermore, closed globe can be any open globe can be any rupture, perforations, intraocular foreign body, and closed globe is your edemas and.
Okay, fine. So basically, it is for mechanical injuries. Fine.
Mechanical injuries.
Thank you.
Yes.
Okay.
Sorry to interrupt, ma'am, but the time is over.
Okay, we can pass on to the next.
So the next participant is Dr. Bhavna Chawla. Are you ready? Dr. Bhavna Chawla.
Hello. Yes, ma'am.
You are here, then
Ma'am,
please start your
can you hear
screen.
me?
Yeah,
She
we
was
can
Yes,
hear
ma'am.
you.
She was supposed
Please.
to talk in the first session, no? But why you were absent?
Yes, ma'am. Ma'am, there was NMC presentation, NMC inspection in our college today.
Okay, carry on.
Start your slides from the initial button.
Yes. Good evening, ma'am. Topic of my paper presentation is toxic optic neuropathy. It is visual loss due to damage to the optic. It is visual loss due to the damage to the optic nerve due to the effect of endogenous or exogenous poisons.
Hello.
The patient complains of gradual and hello. Can you hear me, ma'am?
Yeah, we can hear you.
There is gradual painless progressive bilateral loss of central vision. Patient also complains of fogginess and difficulty in doing the near works. There is bilateral central scotoma with diffuse margins. There is reduced color vision. On fundus examination, there is temporal disc pallor. Causes of toxic optic neuropathy: tobacco, ingestion of methanol, ethylene alcohol, disulfiram halogenated hydroquinolones, ethambutol, and isoniazid, linazolate, chloramphenicol, chloroquine, and hydroxychloroquine. Now we'll be talking about it separately. Tobacco and tobacco abuse-related toxic optic neuropathy. It typically occurs in men, in pipe smokers, and diet deficiencies in protein and vitamin B complex. Toxic agent is cyanide, which is found in tobacco. Pathogenesis: excessive tobacco smoke results in excessive cyanide, because of which there is degeneration of ganglion cells, particularly in the macular lesion, which results in degeneration of capillomacular bundle in the optic nerve. Ethyl alcohol related clinical picture is same as that of tobacco related TON. Methyl alcohol related TON, it typically acute, usually results in optic atrophy and permanent blindness. It occurs due to intake of wood alcohol or methylated spirit. Also occurs due to inhalation of fumes in industries. It is mainly because of formation of formic acid and formaldehyde, which results in edema and degeneration of the ganglion cells, which results in complete blindness. Patient complains of headache, vomiting, dizziness, and abdominal pain, and there is presence of characteristic odor. Patient is usually brought with complete blindness after 2 to 3 days. On fundus examination, there is mild disc edema, markedly narrowed blood vessels, and finally primary bilateral optic atrophy. Quinine-related TON in this pupil is fixed and dilated. On fundus examination, there is retinal edema, marked pallor of the disc, and extreme attenuation of the retinal vessels. Ethambutol-related TON patient on fundus examination, there is sign of papillitis. Idiopathic toxic optic neuropathy can be cortical or subcortical. On physical examination, there is Humphrey or Gold. On physical examination, we do Humphrey or Goldman visual field evaluation, Snellen visual acuity, slit lamp examination that shows the deposits of the drug, RAPD, direct ophthalmoscopy of the optic nerve and retina.
Signs: there is no RAPD when bilateral disease, normal swollen or hyperemic optic disc, temporal optic disc pallor in late detection, central scotoma in visual fields, decreased visual acuity, and there is greater impairment of red or green.
Time's up. Time's up. Over to judges. Judges, please ask the questions. Respected judges, please ask the question.
May we request the judges to please ask? Thank
How
you.
to differentiate it from NAAIN?
Please repeat the question.
How
I
to
want to thank
differentiate
Bhavna for her nice presentation. But
thank you.
I need to know in which year you are.
Ma'am, first year.
First year. So you haven't seen any patient of optic, of this case, I think.
Until now, I haven't seen.
Okay. So what is the main cause of toxic?
Mainly it is idiopathic, which can be cortical or subcortical, and second most common cause is ethyl alcohol or tobacco intake.
How to treat a case of methyl alcohol poisoning at emergency?
Ma'am, first is stop the intake of the offending agent, and
Yes.
ma'am, we give sodium bicarbonate, or we go for hemodialysis or IV pulse steroids.
Good. What is the prognosis in such cases?
Ma'am, if detected early, patient can regain their vision within several weeks, but except in ethambutol toxicity and methyl alcohol toxicity, because in methyl alcohol toxicity, blindness occurs within 2 to 3 days.
Okay. Okay, thank you.
Thank you so much, judges. So our next participant is Dr. Divya Rana. Dr. Divya, are you here?
Yes, ma'am, I'm here.
She was, the last participant name was?
Bhavna.
Bhavna Chawla.
Bhavna
Okay.
Chawla.
Dr. Divya Rana, please share your screen.
Yes, ma'am, I'm sharing it. Just...
Dr. Divya?
Yes, ma'am, I'm trying to share it. Just 1 second.
If there are any technical issues, Dr. Manika Sharma, are you ready?
Yes, ma'am, I'm ready.
Dr. Manika, share
Yes,
your screen.
Is my screen visible, ma'am?
Not yet.
Hello?
Yes, the screen is visible.
Can I start, ma'am?
Yes, you can. You're final year student.
No, ma'am, first year PG resident.
Oh, first year.
Yes, ma'am.
Okay, go on.
Can I start?
Go ahead. Yes, you can start.
A very good evening, respective judges. I'm Dr. Manika from NC Medical College. I would like to thank you all for giving me the opportunity to present my case on cortical blindness. So here I start. Cortical blindness is defined as a loss of vision without any ophthalmological cause and with normal pupillary right reflexes due to bilateral lesion of the striate cortex in the occipital lobes. It is a loss of vision secondary to the damage to the visual pathways posterior to the lateral geniculate nuclei.
The etiology in children would be divided into three subheadings, that is traumatic brain injury to the
Excuse
occipital
me,
lobe
Dr.
of the brain.
Malika, your PowerPoint is
Yes,
not
ma'am.
moving ahead.
It's not
Your
visible.
PowerPoint is not moving ahead. It's just the first slide.
Second.
Dr. Manika, share your screen again.
Ma'am, can you see that? Ma'am, is my PPT visible now?
No, it's not visible.
Again, it's not.
Doctor, stop and reshare, please.
Yes.
If she's having connectivity issues, can we go to the next person, Dr. Monica?
Ma'am, I think she's resharing. We can wait for.
Just a second, ma'am. ये थी ना तेरी?
ठीक है, Dr. Divya can start.
Dr. Divya Rana, please, you start your PPT.
Please start.
Yes, ma'am. Good evening to all the respected judges and
Time
my
to be
fellow
started.
colleagues. I am going to present on my thesis topic, which was the influence of, hello?
All your timing is going to start when you start sharing, please.
Hello, ma'am.
Yes, you are audible. There is a lot of disturbance behind.
Good evening, respected judges and my fellow colleagues. I am going to present on my thesis topic, which was the influence of YAG laser on refraction, intraocular pressure, and anterior chamber depth. So, as we all know, posterior capsular opacification is the most common complication following an uneventful cataract surgery. The YAG laser is safe, quick, and effective method of treating PCO. And since there are a lot of complications associated with YAG capsulotomy, it is imperative that we assess the anterior and the posterior chamber well. So, in my study was a prospective observational study conducted in SGT Hospital, Gurgaon, carried out in 50 patients who were diagnosed cases of posterior capsular opacification, and it was carried out from 2021 to the middle of 2022 and adhered to the tenets of Declaration of Helsinki. We included clinically diagnosed cases of PCO and all the patients who were willing to give informed and written consent and willing to undergo capsulotomy. And we excluded any patients with corneal opacities, glaucoma, any maculopathy, retinopathy, or any history of complicated surgery. So we carried out complete ophthalmic examination for each patient, and we explained the procedure to them, and we carried out refraction using the Snellen's chart and autorefractometer. And the IOP was measured using the GAT, Coleman applanation tonometer, and the anterior chamber depth and angle were measured using the anterior segment OCT. All the readings were taken before the procedure at 1 hour following the procedure, at 1 week, and at 1 month. And please note that before starting the procedure, we did not instill any IOP lowering agent. So the results that were found were, the results that we noted were
What is happening right now? Only I can't hear, or what's happening?
Ma'am, she is not audible.
So anyway, when 4 minutes are up, we have to stop it, Dr.
Yes,
Monica.
ma'am, time's up.
Okay,
Dr.
we can
Divya
stop.
Rana.
Judges, may you please ask questions? Please stop your screen sharing. Can we ask
What was
questions,
the
please? Sorry.
What was the presenter's name?
Anna.
Dr.
Dr. Divya Rana.
Dr. Divya Rana. Who is screen sharing now?
Somebody else. That's cortical blindness.
Dr. Divya, are you there?
Yes, ma'am, I'm there.
The judges may please ask questions.
Yeah, Dr. Divya, I missed the aim of your study. What was the aim of your study?
Ma'am, the aim of my study was to study the changes that took place after carrying out yak capsulotomy in diagnosed cases of PCO. The changes in refraction, in intraocular pressure, and anterior chamber depth.
Yeah, so what were your conclusions regarding intraocular pressure? What was your conclusion?
Ma'am, we noted a spike in the immediate post-op period. Like when we took the IOP after 1 hour, there was a spike noted, and when we took the readings again at 1 week and at 1 month, it was similar to the readings that were taken before laser.
So what your study? Why did you undertake this study? This is something which we expect after yak.
To see the changes and to avoid any complications that may happen. So from this study, we were able to conclude that it is not necessary to administer topical IOP lowering agents in every case if there is no high risk, because the rise in IOP is only transient. And
okay, thank you, Divya. Actually, we missed most of your slides because you were not audible during the PPT. Thank you.
Thank you, ma'am.
So, our next participant is Dr. Manika Sharma. Please start sharing your screen, Dr. Manika.
Yes, ma'am.
And please stick to the time.
Ma'am, is my slides visible now?
Yeah, it's visible. Start, please.
Can I please start? Can I please start?
Yeah. Yes, please start.
A very good evening, everyone. I am Dr. Manika from NC Medical College, and topic for my today's presentation is cortical blindness. Firstly, talking about the introduction, cortical blindness is defined as a loss of vision without any ophthalmological causes and with normal pupillary right reflexes due to bilateral lesion in the striate cortex in the occipital lobes. It is basically the loss of vision secondary to the damage to the visual pathway posterior to the lateral geniculate nuclei. Etiology in case of children, firstly, it is traumatic brain injury to the occipital lobe of the brain, congenital abnormalities of the occipital lobe, or perinatal ischemia. In case of adults, it can be stroke, cardiac embolism, head trauma, occipital lobe epilepsy, hyponatremia, severe hypoglycemia, and Creutzfeldt-Jakob disease. Infection like HIV, eclampsia, MELAS, which is mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. Rarely, transient cortical blindness can be caused by infective endocarditis, hypertensive encephalopathy, and posterior reversible encephalopathy syndrome, that is PES, can be the basic causes in adults. Now talking about the basic pathology of the cortical blindness. Here we can see there is the visual pathway. Now explaining the visual pathway, it starts from the retina and goes up to the visual cortex. Fibers from the retina passes as the optic nerve with ipsilateral temporal and ipsilateral nasal fibers. From here, the nasal fibers cross at the optic chiasma, which further goes to lateral geniculate body, optic tract, lateral geniculate body, and visual cortex with ipsilateral temporal and contralateral nasal fibers. Hence, if there is lesion in the visual cortex, which is my topic, if there's a lesion in the visual cortex, there would be the visual field which would be affected would be ipsilateral nasal and contralateral temporal, which means it results into contralateral homonymous hemianopia. Now, lesion in the visual cortex can be of two types: right-sided contralateral homonymous macular defect, that is cookie cutter defect. Here, the tip of cortex is towards the left side affected. If I'm talking about the left side lesion, then the middle cerebral artery is involved. Left temporal and right nasal fibers are destroyed, which means the field which are affected is left nasal side central and right temporal side visual field is lost. Wherein, in cases of right-sided contralateral hemianopia with macular sparing, visual cortex except the tip, that is left side, posterior cerebral artery is involved, and left temporal and right nasal fibers are destroyed. If these are destroyed, the left nasal side and the right temporal side visual field will be lost. Between fields are always opposite fields are lost in case of this. Now, characteristic findings of the visual field impairment are abnormal light or light gazing, blink reflex, visual threat, that is color, latency, visual novelty. Movements would be affected, visual fields are hampered, visual motor complexity, and distant viewing is also affected. Now, talking about the treatment, it is divided into firstly restitution therapy, which is done to recover visual field defects. Patients detects multiple light spots on the black screen across the blind and normal visual hemi field. Compensation therapy acts by compensating for the visual loss by static eye movements. It helps to capture visual stimuli that would otherwise fall on the blind part of the visual field.
Time is up, Dr. Manika. Time is up. Over to judges. Please
Yes,
ask
thank
the
you
question.
so much. Yes, ma'am.
Dr. Monica, can you please tell me what are the differential diagnoses in a case of cortical blindness? Can you differentiate it from other differential diagnosis of cortical blindness? How do you differentiate it from other conditions similar?
In cases of sometimes in cases of melas encephalopathies, sometimes other hemiplegias wherein the brain is affected, wherein there is hemiplegia, the motor reflexes are lost. In that case, we can see that other way around also sometimes the encephalopathies are involved, and in cases of certain infections like meningitis, which can also present in similar form. In cases like there's a bacterial meningitis or bacterial encephalitis.
From a case of malingering.
Yes, ma'am. Obviously, we have to, by performing certain tests, we have RAPD test to differentiate it from that, and which will actually help us differentiate.
RAPD, you told that there is no changes in the
Yes, ma'am. That is what.
Is not
Yes,
involved, that is the diagnostic feature, and now you tell
that
me
is that will help us to differentiate. That will help us to differentiate between the other symptoms, ma'am. Other symptoms, because in other symptoms that would be absent. This would help us to differentiate.
In malingering, what will be there?
Nothing would be. Yeah.
Is there a simple test to detect malingering and cortical blindness? Otherwise, in your clinic, the patient will make you बेवकूफ बना देंगे तुमको एकदम बेवकूफ बना देंगे. How will you differentiate it? Okay, just think of it.
Different visual gazing, visual movements would be affected. Visual gazing would be present. In other way around, we can see that this only the visual gazing and visual movements would affect the field. Ma'am, basically we can do the field testing also. The fields here we can see that there is sparing of the macular region. And
what will be the visual field?
Sorry to interrupt.
The field would be clear, and in cases of cortical blindness, you can see the visual field changes.
No.
Sorry
to there is no vision. So how will you test the visual field? Okay, carry on. And any other judges can take up question.
Ma'am, time is up.
Okay, I don't have any question.
So we would like to welcome our next participant, Dr. Amandeep Arora. Are you there?
Yes, ma'am, I am there.
Dr. Monica, please announce the next person also so they can be ready.
So the next is Dr. Poonam Juneja. Please be ready.
Good evening, everyone.
Please share your screen.
Ma'am, is it visible?
Yes, it's visible. Please start your presentation.
Good evening, everyone. I am going to present a case on infectious cornea ulcer. I'm Dr. Amandeep Arora from SGT Medical College. History of patient is a 59-year-old male came to OPD with chief complaint of eye pain, redness, watering, swelling around the right eye from last 20 days. Patient was apparently normal 25 days back when he had trauma in his right eye while working in a field from a paddy crop, after which he developed redness, eye pain and watering from right eye, and patient was on irregular treatment for fungal corneal ulcer from a private college in Uttar Pradesh. History of hypertension is present, and history of tobacco chewing is present for last 23 years. On examination, vitals and general physical examination were within the normal limits. Visual acuity in right eye was hand movement present, PL positive, and PR was inaccurate. In left eye, it was 6/9. On ocular examination, right eye, IOP was increased digitally. Eyelid edema was present in conjunctiva. Diffuse congestion and circumcorneal congestion was present. In cornea, 5.5 mm epithelial defect is present, and it was staining on fluorescent staining. And infiltrates were present around cornea. In anterior chamber, 3 mm hypopyon is present, and rest details were not visualized. In left eye, anterior segment is within the normal limit, and fundal glow was present. On investigations, on corneal swab, KOH mount is positive for fungal filaments. On culture sensitivity, growth of Aspergillus niger is seen, and on B scan, there was no abnormality is seen. HP was 14.4, platelet is 2.27 lakh, TLC was 11,000, RBS was 104, and ECG and viral markers were normal. We had started his treatment with the eye drop fortified tobramycin 6 times a day, eye drop moxiflox 6 times a day, netamet half hourly, voriconazole half hourly, timolol BD, atropine BD, tablet diamox 250 mg 4 times a day, and syrup portchlor 1 tablespoon OD. There was initial relief in symptoms, which was followed by worsening of the ulcer, which was seen as cornea was diffusely hazy, vascularizations started to appear inferiorly, and plaques were present on the endothelium. And anterior chamber details were not visible. It was followed by patient had undergone anterior chamber wash with intracameral amphotericin B under LA. There was initial improvement in symptoms for 24 hours, followed by the worsening. On ocular examination, corneal melting is seen, and auto extrusion of intraocular contents is seen, which is followed by which patient had undergone evisceration under LA. Summary: on admission, corneal scraping was.
Time is up, Dr. Amandeep. Over to judges. Please ask the questions.
Yeah,
Dr.
Amandeep.
Amandeep. Okay, you are. Carry on.
Yeah, thank you, madam. So, yeah, this is Aspergillus niger you're talking about, na? So, what is the drug of choice for this fungal keratitis, Aspergillus? What is the drug of choice?
We'll start with topical netamycin. Followed by
actually. Okay, followed by
systemic drugs, and then amphotericin B.
Actually, voriconazole and amphotericin B. These are the drug of choices for this particular fungal keratitis, as far as I know. I am a little troubled by your, the series of drugs which you have. There were about 5 drops and 1 atropine eye ointment BD, and there was no oral antifungal. So, it was managed medically. I'm a little troubled by it. Maybe I would have managed the case in a different way. That's my comment on your case.
Yeah, he is in which year? PGT, first year or second year?
Second year, ma'am.
Second year. Okay. So there is no picture or image. Is there any figure?
Ma'am, there are pictures. I was unable to add it in the presentation. There was some error.
You could have drawn it yourself, no? You could have drawn it yourself.
Okay, ma'am.
How you, on the basis of hypoparon, how you differentiate a bacterial and a fungal keratitis? Just by looking at the hypoparon.
Ma'am, we'll tilt patient to the lateral side and see if hypopion is moving to that side, affected site or not. That in this way we can differentiate between fungal and bacterial hypopion.
What will be your inference?
Ma'am, in bacterial hypopion, it will shift to the affected site, and in fungal, it will not shift.
Affected side, not exactly affected side. It is a mobile hypoparon. Why
Yes, ma'am.
in fungal keratitis, while the hypoparon is not mobile?
Ma'am, because of hyphae present, so that's why it is not mobile, ma'am.
In which case of fungal keratitis, you will add an oral antifungal agent. What is the indication?
Ma'am,
You may not answer, no problem. You say that I don't know.
I don't know, ma'am.
Okay, thank you, thank you.
Thank you, ma'am.
So now I would like to invite Dr. Poonam Juneja. Are you there? Dr. Poonam Juneja?
Yes, ma'am, I'm here. Am I audible, ma'am?
Yes, you are audible. Please start sharing your screen.
Yes, ma'am.
Dr. Vaishnavi, be ready with your presentation.
Is it
Dr.
visible,
Monica,
ma'am?
how many have been done?
Ma'am, 5 are done.
Okay, okay, good. Thank you.
Is it visible, ma'am? Am I
Yes,
audible?
it's visible. Please, yes, you are audible
Okay,
and
ma'am.
visible. Both, please start.
Perfect. Okay. Good evening, everyone. Good evening, respected judges. Myself, Dr. Poonam Juneja. I'm second-year resident at Santosh Medical College and Hospitals, Ghaziabad. Today, I'm going to present a case report on thyriasis palpebrum. So, a 25-year-old male attended the OPD of Santosh Medical College and Hospital with the complaints of repeated episodes of itching and pain in both eyes since 1 month. Patient was apparently asymptomatic 1 month back when he complained of eyes.
Excuse me, Dr. Poonam.
Poonam, I think your connectivity is low. Your connectivity is low. You're not audible.
Please check your network, Poonam, or you can reshare your screen. Dr. Poonam, are you there?
I think connectivity is low at her end, madam. We can move on to the next speaker.
We can move on to the next one, right?
Dr. Vaishnavi, please start sharing your screen. Dr. Vaishnavi, are you there?
Yes, ma'am. Yes, ma'am.
Please share your screen.
The rest of you, please be ready to go at any time because somebody's connectivity is weak, then we'll move on to you. Thank you.
Ma'am, can you see my slide?
Yeah, we can see your slide. Start your presentation, please.
Good evening, everyone. Myself, Vaishnavi Singh from Santosh Medical College and Hospital, presenting pathophysiology of sudden diminution of vision in both eyes of elderly individual. Health problems in old person. About 64 per thousand elderly person in rural area and 55 per thousand in urban area suffer from one or more disability. Blindness is 1.7% in rural area and 1% in urban areas. Leading cause of age-related vision loss. Most old people and CRBO. Age-related macular degeneration, also called as senile macular degeneration, that is bilateral, common above 65 years of age, leading cause of blindness in developing countries. It is of two types, non-exudative or exudative. Most commonly, the sudden vision loss is in exudative wet type. Brush membrane, a pentalaminar structure. First, we will discuss this. It consists of basement membrane.
Dr. Monica, am I not hearing? Or?
No, ma'am, I'm not also hearing. I'm just writing them. Please ensure their net connectivity.
So are they in the middle of a presentation right now?
Yes, ma'am.
Okay, so can we move on to the next person? There's no point spending time on this, right?
Yes, ma'am.
Others are also not able to hear?
No. Dr.
It's
Madhu,
all
are you
frozen.
there?
Who is this candidate, Dr. Monica?
Ma'am, she is Dr. Vaishnavi, and before her was Dr. Poonam Juneja.
Dr. Vaishnavi, please stop sharing your screen, and the next candidate, who is it? Please start.
Dr. Madhu, are you there?
Ma'am, this is Dr. Poonam Juneja. Can I restart my presentation?
Yes, please restart.
Has Dr. Poonam tried earlier, Dr. Monica?
Yes, ma'am, she has tried earlier also.
No, it will be tomorrow last. Whoever has tried and not attempted, we cannot allow them to present today. They'll please write their names at the end of the list tomorrow. It's not possible.
Dr. Madhu, are you there? Dr. Madhu?
Yes, ma'am.
Are you there?
Yes, ma'am.
Please start sharing your screen.
Because I can understand genuine problems, but then for us, it's also a time crunch. We cannot, already we're going to go on till midnight, so we cannot afford to be so late. And all our judges, we are very grateful, but we cannot penalize them like this.
Dr. Madhu, please start sharing your screen.
I'm just starting.
Dr. Gagan and Dr. Renu, please be ready with your presentations and ensure the connectivity.
Restarts will not happen during the same session.
Yes, it's visible.
No second chances right now. Tomorrow we'll see if we have time, because not your fault, but not our fault either, right? Okay.
Can I start, ma'am?
Yes, please start.
A very good evening to respected judges. Myself, Dr. Madhu from Santosh Hospital, Ghaziabad. I am presenting a case of ophthalmic manifestation in Stevens-Johnson syndrome. A 23-year-old male patient, Sahil, residing in a Faridabad, Ghaziabad, presented to the emergency department with a chief complaint of sore throat, fever since 7 days, generalized skin rashes with extensive blistering and swelling in upper eyelid of both the eyes since 3 days. Redness, blurring, and foreign body sensation and watering was also present in both eyes since 2 days. Patient was apparently asymptomatic 7 days back when he developed sore throat and fever, for which he has taken some unknown medication from a local practitioner. After 3 days of taking medication, he developed rashes, which was non-pruritic, and then the blisters started developing on the trunk and extend towards the upper limb and the face. Next day, the eyelid and the lip swelling started developing along with the mouth ulcer, and there was a severe discomfort while trying to open the eyes. In the past history, patient is on anti-epileptic drugs since 5 years of age group, and he's taking carbamazepine 200 milligram BD, and the last episode of seizure was 5 months back, and no relevant history of a family and a personal history is present. In general systemic examination, patient was well oriented to time, place, and person. His vitals are these, and temperature was 101.2 Fahrenheit. In systemic finding, hemorrhagic crusting of lips was present and the blistering involving the tongue and the oral mucosa, mucosal rash extending from the extremities to the face. And this is the picture of the patient. And in ocular examination, best corrected visual acuity was 6/6 in both the eyes. Swelling of upper eyelid was in both the eye was present. Matting of eyelashes was present in both the eyes. Conjunctival chemosis was present, and bilateral conjunctival hyperemia, which was associated with the purulent discharge in both the eyes. In this picture, we can clearly appreciate the chemosis, discharge, and the matting of the lashes. After doing that, the fluorescence staining was negative, and the rest of the anterior segment and the fundus examination was found to be normal in both for the patient. Upon investigation, WBCs was raised and ESR was also raised 68 mm per hour. Blood culture and rapid plasma reagent tests were negative. Anti-DNase tests were negative. On skin biopsy, subepidermal inflammation and necrotizing infundibular epithelium and necrotic keratinocytes were seen. And the provisional diagnosis was Stevens-Johnson syndrome, toxic epidermal syndrome, erythema multiformis, staphylococcal skeletal skin syndrome. And based upon the clinical finding, blood investigation, and the skin biopsy, diagnosis of Stevens-Johnson syndrome was made. In treatment part, oral antibiotics was given, paracetamol, mupirocin, betadine goggles, IV fluids, and ocular involvement was done. Ocular involvement was treated with the topical antibiotics, lubricants,
Time
and the
is
lid
up.
hygiene was advised.
Time is up. Time is up. Please stop your presentation. Over to judges. Please ask the questions.
Dr. Madhu, what is the difference between SJS, Stevens-Johnson syndrome, and toxic epidermal necrolysis?
Yes, ma'am. In Stevens-Johnson syndrome, the total body surface area involvement is less than 10%. But ma'am, in the 10, it is more than 30% involvement of the total body surface area.
Right. What drug was involved in your case?
Ma'am, actually, the patient has taken some unknown medication 2-3 days before the symptoms arise, and he's also an anti-epileptic drug like carbamazepine, but he was on that drug since 5 years of age group, and recently he has taken some unknown medication, so that medication must have interfered for that.
Okay. What are the most common medications which cause SJS?
Ma'am, sulfa drugs are included, and in ma'am anti-epileptic drugs like carbamazepine and the phenytoin, these are involved, and allopurinols, which are given in the case of the gout for the treatment of a pain.
Okay, thank you.
Dr. Madhu, what are the complications of ocular involvement in SJS?
Ma'am, like in this case also, my patient got symblifron formation in the left eye.
How you can prevent? What is out of the prophylactic measures you should take during this period to prevent?
Ma'am, if the patient, the ones get the symptom in the acute phase, and if there is any involvement of the ocular feature, at that time only, during the acute phase only, we should start the patient with the ocular topical antibiotics and the lubricants.
That's all. Any other thing you should do? Once you are saying that it has started developing symblepharon, what will you do?
Ma'am, the moment the symblefron formation has started, we should we should break it with a glass rod passing. If the glass rod should be passed, and it should be breaked.
Very good. Very good. Okay.
Thank you. So our next
Dr. Mili, you have anything to ask? You can ask.
So our next participant
from Bangladesh.
I think Dr. Millie is having internet connection. She has posted on the group. Dr. Millie had written there's some connectivity problem. So
I have some connectivity problem. Yes. I can't hear the presentation. So yes. I'm relying on the questions you are asking them. Okay. I'm marking on that.
Okay. Thank you.
Ma'am, but now you can ask if your connection is
now the connectivity is good. Maybe I will ask question now.
Okay, thank you.
Thank you.
Thank you. Dr. Monica, next candidate.
Yes, ma'am. Dr. Gagan, are you there? Dr. Gagan.
Next.
Dr. Renu.
Yes,
Dr. Renu, are you there?
Yes, ma'am.
Please start sharing your screen, Renu.
This is the 8th candidate, Dr. Monica.
Ma'am, she is the 10th candidate.
Oh, wonderful. Monica, everything on time. Good.
Dr. Vaishnavi finished? Because I don't have.
Vaishnavi and Poonam Juneja, they didn't
Ma'am,
present.
they had to discontinue. Their slides froze in the middle. So, and they could
Oh.
not be audible. So they had to discontinue in between. We'll try to fit them in a later session.
Okay.
Yeah.
Ma'am, my slide is visible.
And ma'am,
Yes,
if you
it's
can mark
visible.
them, please mark them. We may not be able to fit them later. We'll try our best.
Ma'am, can I start?
Monica, your
please
slides
start.
are not visible. Your slides are not visible, Monica. Share your
Screen is not, your presentation is not starting.
Dr. Renu, please start your presentation. Your screen is visible, but your presentation is not yet started.
I'll request all candidates to put on their videos also if possible.
You open your presentation and then do screen sharing.
Can I start, ma'am?
Yeah, please start, Dr.
Start,
Renu.
but only if your presentation starts, na?
Okay. Good evening, judges. Myself, Dr. Renu.
No, it's
Please
not.
start
It's not
your
starting.
Renu, put the slide share, then you start.
Doctor, first open your presentation, then do the screen share. Do not open your presentation after screen share. Please open your
Right.
presentation first,
Yeah.
then do the screen share.
All the candidates, please open your presentation, keep it minimized, and when you do the screen share, you share that.
I've stopped it. Just start again, please.
Who is presenting right now, doctor?
Dr. Renu is here, ma'am.
So then Dr. Gagan, please put off. Who's Dr. Gagan? I have not one
Hello,
of the judges.
ma'am. Hello.
Hello. All the other people who are
Yes,
not
ma'am, I am Dr.
judges
Gagan.
or
Can you
moderators,
see?
please put off your mics. Thank you.
Hello.
Yes, Dr. Gagan is here.
Yes, ma'am. I'm Dr.
Please start your presentation and share your screen, Gagan.
Yeah, this will be the last in this session. Or Monica, we can have 11 since the session is going so beautifully.
Okay, ma'am. Okay.
1 second. Can you hear me, ma'am?
Yes, we can hear you and your screen is visible. Just maximize it and start.
Okay, ma'am. Good evening, respected judges. I am Dr. Gagandeep Kaur from Santosh Medical College, Ghaziabad. I am presenting on penetrating ocular injuries. First is wait, ma'am. Wait. Also, the ocular injury. Hello.
Please start your slideshow.
Okay, ma'am.
So Monica, all this will be counted in the time.
Yes, ma'am, it's already being counted.
Also, the eye is well protected by the orbit. It may yet be subject to injuries. Forms of the injury include foreign bodies, blunt trauma, penetrating trauma, chemical and radiation injuries. Risk factors. Gender, 75 to 80% of them are in males. Age, more common in children and then young age group. Occupation, construction and industry, sports, boxing, racket sports, and motor vehicle activity. When a foreign body passes through the ocular coat of the eye, this will cause damage in the ocular structures, and in some cases, the foreign body may also be retained in the eye. Penetrating injury of the eye represent major threat to the vision in a workplace and home. Effects of the penetrating ocular injuries, mechanical effects, such as the lacerations of the conjunctiva, corneal lacerations, vitreous hemorrhage, rupture of the globe, retinal tears, and detachments. Scarrings which lead to cataract, glaucoma, and intraocular foreign body. Introduction of the infection. The entrance of the wound may serve as a route of entry for the pyogenic bacteria, which may lead to the formation of abscess of the cornea, purulent iridocyclitis, or endophthalmitis. Sympathetic ophthalmitis, it is the complication of penetrating injury. Main symptoms are redness of the eye, hemorrhages, congestion, lacrimation, photophobia, inability to open the eye, blurring of vision, change in the pupil shape, blood or fluid leakage. Don'ts and do's for
injury, don't flush the eye with the liquids other than saline, or even better, just don't touch the eye. Don't remove the object out of the eye. Do not put any pressure on the eye, and do not rub your eye. Reassure the person and advise against rubbing or moving their eyes, as this can cause further damage. If injury is severe, place moist pad and loosely bandage the eye. Transport the patient to the nearest hospital as soon as possible. This is the picture of lid laceration.
Dr. Gagan, time is up.
Okay.
Over to judges. Please ask the questions.
So, Dr. Gagan,
what message of penetrating eye injury? The most important complications, you will say.
Yes,
penetrating eye injury. What are the most important complications?
What most important?
Complications.
Ma'am, wait.
Okay, you tell me what is the dreadest complication of penetrating eye injury? Though it is rare, but it is the dreadest complication. What is that? I'll give you some hints, which was very common few decades back, but now it has become rare. What is that?
Dr. Gagan, if you don't know the answer, please at least respond.
I have one question to ask.
Okay.
Can I ask?
Yes.
So
yes.
what message do you want to give to the people by your presentation, this presentation?
Dr. Gagan, are you there? Dr. Gagan.
Disappeared after listening the questions, I think.
Dr. Gagan?
Dr. Gagan, are you there?
Disconnected. We are disconnected.
Disconnected.
Mr. Sunil, please stop sharing her screen so that the next candidate can share the screen.
I think we Poonam, Vaishnavi, and Renu failed to appear. So
yes, ma'am.
Are they going to present today?
No, ma'am. They will be given chance on the next day, as we are already
not
short
possible
of time.
today. Not possible today.
Okay, then we are done for today.
Ma'am,
Yes,
have we done 10 people?
Ma'am, 7 are done, 3 are absent.
3 are
No, we have to have 10 presentations in this session.
1, 2, 3, 4,
Because all the
5,
absentees will land up on our head tomorrow.
6, 7 is there.
Dr. Monica, who else? Can we have some more? There are some more people there, Dr. Nupur and all.
Yes, ma'am, I am seeing. Dr. Nupur, are you there?
Yes, ma'am, I'm here.
Please present.
Please present and start sharing your screen,
yes,
Dr. Nupur.
This
And Dr. Shivangi, be ready next.
And one more. We have to have 10 in this session, okay?
Yes, ma'am. Dr. Kashish, Dr. Shivangi, and Dr. Nupur.
That's it. Okay. And for the rest, the second attempters, we will see tomorrow. We'll try our best, but we cannot guarantee because of the time crunch. You were given
Dr.
adequate
Nupur?
and more time today. And unfortunately, not your fault, not our fault. Okay?
Ma'am, I'm just sharing my...
Please share your screen.
Yes, ma'am. Yes, ma'am. Ma'am, can I please come back after the next this thing? I just have to change my system settings.
Next time we do not want this. Otherwise, we will not
No,
allow it
ma'am.
again.
I just have to change the settings. It will just take
I know everybody just has to change the settings. Please don't argue. Okay? You're still wasting our time. Dr. Monica, next person, and we'll take her at the end, whoever this is.
Yes, ma'am. Dr. Kashish, are you there?
Yes, ma'am.
Because
start sharing your
whatever,
screen.
it may be just a glitch for you. It is very, very valuable time for our judges and a whole team of people who have been working for this. So please practice beforehand. Keep your presentations open. Minimize them.
Dr. Kashish,
is my screen visible to you?
Yes,
Perfect.
it's visible and you are audible. Please start your presentation.
Good evening, everyone. I am Dr. Kashish Goyal. I am going to present a case report on branch retinal vein occlusion. A 43-year-old male resident of Ghaziabad presented in the OPD with the chief complaints of diminution of vision in both eyes since 1 month, right eye more than left eye. The patient was apparently asymptomatic 1 month back when he developed sudden painless diminution of vision. There was no history of headache, pain in the eye, or redness. The patient has had a similar complaint in the right eye 10 years back, for which he received an intravitreal injection once at a different institution in 2013. At which time his best corrected visual acuity was 6/9 in the right eye and 6/6 in the left eye. There was no history of diabetes or hypertension, no significant surgical history, family history, or no history of smoking or alcohol. The patient's general examination was well within normal limits. On ocular examination, the patient's best corrected visual acuity was 6/24 in the right eye, 6/9 in the left eye. Intraocular pressure was 17 mm Hg in the right eye, 14 mm Hg in the left eye. And on slit lamp examination, the lids and lashes were normal, and anterior segment was well within normal limits in both the eyes. On fundus examination, the disc was normal in shape, size, margin, and color, and the CD ratio was 0.3 in both the eyes. Now here you can see a fundus picture of the right eye, which shows a macular hemorrhage just below the superior temporal arcade involving the macula. FR is dull, and there are cotton wool spots as well. This is a fundus picture of the left eye showing a superotemporal hemorrhage just above the superior temporal arcade with cotton wool spots, and showing FR dull in the macula with hard exudates. Also in the right eye, there was cystoid macular edema. Now, as you can see on the OCT, there are cystic spaces along with subretinal and intraretinal fluid and retinal thickening in the right eye OCT, and the left eye OCT appears to be normal. On several investigations, we found that complete blood count, KFT, LFT, blood sugar fasting, all were within normal range, but the lipid profile was a bit deranged. Total cholesterol was 256 milligram, which was borderline high, and LDL cholesterol was 184, which made the patient high risk, and the serum homocysteine levels were very high, which was 28 mole per liter. There were no cardiovascular abnormalities, and PT, APTT, INR was normal. On the basis of fundus examination, OCT images, along with the correlation of the blood reports, we came to the conclusion that the patient had bilateral BRVO, branch retinal vein occlusion. He had macular BRVO with cystoid macular edema in the right eye and a superotemporal BRVO in the left eye. The treatment, an anti-VEGF intravitreal injection, a 0.5 milligram bimacizumab, brand name Avastin, was given in the right eye because of the presence of massive macular edema. In the left eye, laser treatment was given, followed by an anti-VEGF intravitreal injection, a 0.5 milligram bevacizumab 1 week later. And after the patient was followed up 1 week later, you can see in the right eye OCT, the macular edema has drastically reduced.
Time is up. Over to judges. Please ask the questions. Judges, please ask the questions.
Dr. Kashish?
Yes, ma'am.
Please tell me why this superotemporal BRVO is the commonest.
Ma'am, because the maximum number of AV crossings are present in the superotemporal region.
Very good. Very good. In your case, what do you think is the risk factor or cause in your case for this BRVO?
Ma'am, actually, the patient had high homocysteine levels, which makes the patient prone to thrombosis recently. That is why he's had a recurrent attack of BRVO this time.
Okay. Then how you are going to follow up your case?
Sorry, ma'am?
How you are going to follow up your case?
Ma'am, we'll call the patient every 4 weeks, and if the patient is responding nicely to the anti-VEGF injection, we'll continue with the anti-VEGF injections every 4 to 5 weeks, according to the response of the patient. If the edema, because as soon as we gave an anti-VEGF injection in the right eye, the edema has drastically reduced. So we think the patient is responding very well. And since he's had a recurrence, we'll try to keep giving him laser therapy and anti-VEGF injections.
Okay, thank you. Well done.
Time is up. So our next participant is Dr. Kashish. Are you there?
Ma'am, I've just presented.
So Dr. Shivangi, are you there? Please stop sharing your screen.
Yes, ma'am.
Good evening. Who is she, Dr. Shivangi? Are you there?
Ma'am, yes, ma'am.
Yes,
Who was
please
the
start
last presenter? Who was the last presenter?
Dr. Kashish was there, ma'am.
Kashish.
Yes.
Kashish.
Now
Dr.
is Dr.
Monica,
Shivangi.
this will be the 10th person to present.
Yes, ma'am. This is the 10th presentation today.
And please tell us after this, we'll take a roll call of who all is left. Otherwise, we'll cancel the last session.
Yes,
Otherwise,
ma'am.
there's no point. We're not going to keep waiting for candidates.
I have one question. Is it the 10th presentation or 9th presentation?
This is the 10th, ma'am.
10th.
2, 3, 4, 5.
There
6,
have been 2 who could not complete, no, Monica, in between.
8.
Yes, ma'am. There were 2 who could not complete, and third was the Nupur. There were 3 people who could not
But we will
complete.
count them as presentations because they presented. If they got stuck on the presentation due to whatever reasons, actually the presentation has been done. So, Dr. Poonam, your presentation is over. And the next person, who is that?
Ma'am, Dr. Nupur and Dr. Renu, I think.
Ma'am, I'm here.
Who
so
are
their
you?
presentations are over. They've
Dr.
already
Shivangi.
Yes, ma'am. I'm ready with the presentation.
Please start your presentation, Shivangi.
I'm Dr. Shivangi Trehan from Santosh Medical College, and I'm presenting on toxic amblyopia. Here are the various headings that we're going to go through in this presentation. Introduction: amblyopia is the partial reversible loss of vision in one or both of the eyes for which no cause can be found by physical examination of the eye. That is, there is absence of any organic disease of ocular media, retina, and visual pathway. In toxic amblyopia, visual loss is due to the damage of the optic nerve fibers due to the effect of exogenous or endogenous poisons. Etiopathogenesis: many nutritional deficiencies, toxic and hereditary optic neuropathies, they produce a very similar clinical picture because there are common pathways by the vitamins and these toxins interact. Within the mitochondria, oxidative phosphorylation involves the production of ATP at the other end. The net result of these deficiencies and toxins is the decreased production of ATP by the mitochondria within the cells of the body. So pathophysiology: there are many causes of toxic optic neuropathy. Alcohol is one of them. Chronic alcoholism leads to vitamin B12 or folate deficiencies that impairs the ATP-dependent axonal transport system. In methanol specifically, it oxidizes to formic acid and formaldehyde, and it causes focal retrolaminar optic nerve delamination. Linzolate: prolonged linzolate uses can interfere with mammalian ribosomes and lead to the disruption of mitochondrial oxidative phosphorylation. Ethambutol: it has been hypothesized that the induced optic neuropathy may be possibly due to the disruption of the oxidative phosphorylation, which is secondary to the decreased free copper in the mitochondria. Amidaron interacts with polar lipids and accumulates as inclusion bodies in the optic nerve, and sildenafil acts as an inhibitor of phosphodiesterase again. Here is the ethambutol toxicity fundus picture, which shows bilateral sphincter hemorrhages and mild left optic disc swelling, and the OCT for amidaron toxicity shows ERM with marked distortion of foveal contour, retinal thickening, and intraretinal cystic changes. The D picture. Then in lead, it can bind with the melanin in the RP, choroid, iris, and ciliary body with high affinity and disrupts the cellular biochemistry. Clinical features: symptoms: loss of central or paracentral visual acuity, reduced contrast perception, general loss of color perception, particularly red, photophobia, poor dark adaptation. Signs is in the early detection: normal, swollen, or hyperemic optic disc, temporal optic disc pallor in the late detection, centrocecal scotoma, and with preservation of the peripheral field. And ethambutol, it causes bitemporal hemianopia and obviously decreased visual acuity. Then this photophobia, abnormal VP or ERG. In diagnosis, it is a diagnosis of exclusion. We have to have a history of drug medication and visual loss and prognosis of visual loss, dyschromatopsia, central and centrocecal scotoma, papillomaculary bundle. Then the history, we have to take the whole detailed history of the uses of systemic medication, tobacco, metabolic diseases, family history. Physical examination is on Goldman visual field evaluation, Snellen visual acuity, slit lamp examination, swinging flashlight test, or DO. And diagnostic procedures include MRI, VEP, OCT, Ishihara.
Time is up. Time is up.
Okay, ma'am.
Over to judges. Please ask the questions.
Hello, you are Dr. Nupur, or what is your name?
Ma'am, Dr. Shivangi.
Dr.
Shivangi.
Shivangi. Dr. Shivangi, very good presentation. Now, can you tell me how you differentiate it from a case of bilateral optic neuritis?
Ma'am, in optic neuritis, there are various other features which are available, like Athav's phenomena, Pulfrit's phenomena that is there, and which will not be there in amblyopia, toxic amblyopia. And toxic amblyopia will always be having a history of uses of drugs or any vitamin deficiency, which can be found in correlation with the blood levels, which we can do with the patients, like vitamin B12 deficiency, folate deficiency. or any other
And
deficiency.
regarding prognosis, which one is you think is a better, the toxic amblyopia or optic neuritis?
Ma'am, in optic neuritis, the visual acuity is returned back after methylprednisolone, and if the patient is suffering from multiple sclerosis, the patient might not even need methylprednisolone, and visual acuity returns on its own after a weeks or months. It is not a diagnosed period, determined period that it comes back. And in toxic amblyopia, the prognosis is basically in 4 to 6 weeks we have to follow up, and in 6 to 12 months it can come back. But it like in ethambutol toxicity, that is irreversible.
Okay. Very good. Thank you.
Hello, can we?
Yes,
Dr.
Hello.
Monica, how many
Yes,
candidates have presented?
Ma'am, I think total 10 are done and 4 are left because of their issues on the network
That's
side.
okay. That's okay. We cannot deal with that. We cannot give anyone a second chance until we give everyone a second chance. That may not be possible because there may be many people stuck tomorrow also. So,
Yes, ma'am.
so we 10
And
are
ma'am,
done in this
I
session.
think, ma'am, there is no one left for the third session. We are all done for today.
Any other people for the third session in the group? Dr. Ruchi, are you there? Dr. Ruchi?
Yes, ma'am. I am very much there, ma'am.
So, if there is there anyone left for this third session now?
Ma'am, I have put again 3 times. I have put the message, but no one has given any this thing written message about their present.
Okay.
Ma'am, what we can do if
we
we are
can
left
allow,
with only 4 people, we can allow them to.
Now we can
present
allow
and we can
because
bring to them.
others are not there, so we will allow all 4. We have to be fair in this.
Yeah.
So congratulations, you guys. The 4
We
people
can
who
allow
are who've been killing us with messages, go ahead.
Right.
Excuse me, ma'am.
Commission of judges. We have to ask judges first. Respected judges.
Can we allow 4 of them?
Dr. Monica, we'll allow 4 of them.
Yes, ma'am. Can I give over to Dr. Ruchi?
Yes, Dr. Monica. Prithvi is calling you. Go. Thank you so much.
Thank you. Thank you so
Dr.
much.
Ruchi, Dr. Ruchi ka mauka.
Yes,
Okay. Okay. Dr. Vaishnavi, Dr. Poonam, Dr. Nupur, or are you all there?
Yes, ma'am, we are here.
Yes, ma'am. One by one, all of you will get a chance. It's either none or all. We would like to give you all a chance, and we must thank our judges for being there at midnight. Okay. Chalo, 1, 2, 3, start. All the best. Dr. Ruchi?
Yes, ma'am. So, yes, who are we going to start with? Who is ready? Please start sharing your screen.
Ma'am, this is Dr. Poonam Juneja. Shall I start?
Yes, I think we'll be having the same judges, ma'am.
Dr. Ruchi, can we ask Dr. Indermohan also to join if he's there, and the last panel judges also? Who all are there in the last panel?
Yeah,
madam, I'm there.
ठीक है जी बस. Okay, good. So thank you so much for being there.
And Dr.
Panel of
Dr.
judges.
Sarveshwar is also there.
Thank you, ji. Please grade these students.
Welcome, Professor Sarmishta Behra from BSS Medical College, Burla, Sambalpur, Odisha.
Yes, sir.
Thank you.
Sir.
And where is
Namaste,
my
sir.
good friend, Professor Inder Mohan? Professor Inder? Yes, Inder is there. So
Hello,
let's
sir.
start the game under the captaincy of great lady of Haryana, Hurricane lady, and Professor Manisha Rathi. Thank you, madam. Carry on. Carry on.
Thank you, sir. 4 more candidates. So we will
And already we have got the Haryana Hurricane, Professor Sajdev, Sumit Sajdev. From the evening, both of them are very much active and making this very much interesting. Carry on, carry on.
Thank you, sir.
Thank you, sir.
Thank you. Carry on. Now you see, from all the parts of India, people are coming and joining this, and that's good. As well as from Bangladesh, tomorrow there will be from Nepal. Rajesh. Thank you.
Thank you, sir. Thank you. Dr. Ruchi, over to you.
Sir, you infuse the energy level into them. That is why they are again charged. Sir has again infused energy, so they are charged.
Sir is the most youthful out of us all. Sir is the youngest. Chalo ji. Dr. Ruchi, over to you. And welcome to Dr. Inder Mohan and our next panel of judges. Thank you so much for being here.
Thank you, ma'am. So let's start. Who is going to present? Dr. Nupur, Dr. Vaishnavi.
Ruchi, just say one name and let her present and then say the other name. Yeah.
Okay. Dr.
Dr.
Vaishnavi.
Nupur, you can present.
Yes,
Dr.
ma'am.
Nupur,
Ma'am, Dr. Vaishnavi.
Again, there's a problem with that.
Ma'am, can you hear me?
yes, we can hear you.
Hello.
Start
Yes,
sharing your screen.
Okay, and now, please, you people have killed us with messages. You're getting a second chance. Be grateful to our judges. But now, no more chances after this. Okay, all the best. Go ahead.
Your time starts
now. No, abhi inko screen share hone do. The screen share starts. But if it doesn't happen in 30 seconds, I'm sorry. That's all we got. Start. Koi to karo. 4 of them have been, messaging and messaging and messaging. Dr. Vaishali, Dr. Nupur. Okay. Chalo. Start.
We have Dr. Nupur. Okay. Yes. Time
Nupur
starts now.
Bhatnagar.
Yes, sir. I'll just start. Just a second. Is my screen visible?
Yeah,
Yes,
yeah.
visible
Yeah,
and
good
audible
evening,
also.
good evening, sir and ma'am. Thank you for giving us this opportunity. So my topic is on the steps to evaluate ocular trauma in the first visit. I am a JR1 from SMCH Medical College. As soon as the patient comes to us in the trauma department, we have to check the basic A, B, C, D, E of any trauma. We have to assess if there is any systemic emergency that requires prior investigation and treatment, or is there any ophthalmic emergency. Accordingly, if we have an ophthalmology emergency, we have to segregate so that we know which is to be prioritized first. First, we have to ascertain the type of injury, mechanical, chemical, or thermal, since chemical injuries are to be assessed first, and eye wash is to be instilled. After that, we have to classify according to the best classification of mechanical trauma. We have to classify the global injuries. We have to ascertain the type, grade, the presence of RAPD, and the extent or in any ocular trauma, which are different for open globe injuries and closed globe injuries. After which we have to take a quick and brief history taking, but it has to be complete. We have to know the age, occupation, what are the present symptoms, what is the source and mechanism of injury, how long was the injury implicated, were there any steps taken before this, are there any similar ocular history, and is there any present medical history or any previous surgical history. And we have to, documentation is very important in case of trauma. In cases of chemical and thermal injuries, like we discussed, it has to be treated immediately. Any blunt trauma can cause rupture to the eyeball. Sharp objects can cause mostly lacerations. We have to know the type of foreign body which was implicated with the trauma, like inert ocular, intraocular foreign bodies. They are less reactive than any metals involved. Then we have to know, is there any plant involvement to rule out any fungal corneal ulcer or fungal involvement. Then we start off with the ocular examination. We have to know, is there any open globe injuries to not ascertain any more, to not implicate any more worsen the symptoms. Then the patient has to be examined preferably in the sitting position rather than the supine position. Children are to be assessed in the parent's lap. And if there is any pain, we have to instill topical anesthetic. Or lid retractors or speculums can be used to help in the examination. Inspection, we have to know the location, size, and appearances, know if there is any proptosis or an ophthalmos involved. Then we have to take the visual acuity, both the eyes, both the injured and the fellow eye, and it has to be medically recorded. Then we go for orbital wall fractures, then any ocular motility. We have to know that direct muscle or cranial nerve trauma is very rare. And if the ophthalmoplegia cannot be explained by adnexal or orbital injury, then a neurosurgical reference should be taken. Visual fields can be taken by confrontation test. Then intraocular pressure, It is done only in cases of closed globe injuries and not done if there is any open globe perforation. Low pressure means there can be any globe perforation. High is expected even in early cases of contusion. Torchlight examination, photographic and diagrammatic representation is very important. Pupil shape, size, position, we have to know if they are symmetrical. Dilatation can be due to sphincter hemorrhage, and
Dr.
isoporia
Nupur,
can
your
be
time is over. Please stop.
Yes, ma'am.
It's over.
Yeah, can
Over
I
to
ask a
you.
question? Can I ask a question now?
Yes, ma'am.
Please, ma'am.
How do you differentiate between perforating and penetrating injury?
Ma'am, penetrating is a through and through trauma, whereas perforation is only one-sided globe trauma. I mean, both the sides of the globe is not lacerate, pierce.
Would you like to revise? Okay, you said torchlight examination. Now, what is torchlight examination?
Ma'am, external inspection on.
We can do it under the slit lamp.
Ma'am, in emergency setting, if we don't have a slit lamp available in that time in a trauma setting, only then under the torchlight.
Okay. Can you explain traumatic meiosis?
Ma'am, traumatic meiosis can be due to sphincter perforation, any trauma.
Then what is traumatic mydriasis?
Oh, yeah.
Okay, then anyone else wants to ask? Sir, Inder sir, namaste sir.
Yeah. Namaste, ma'am.
Namaste.
Yeah, Nupur, what is the most important radiological investigation you would like to know?
So, gold standard would be CT of the orbits.
Okay.
If
Are you
not,
sure?
Yes.
First and foremost.
So first, I would like to do a plain X-ray, AP and lateral view.
Okay.
Yes.
Right. And why do you want to take photographs? How does that matter?
Sir, due to
Photography
medical legal importance, then to counsel the patient, because in such cases the visual prognosis differs gradually in the due course of the trauma. So we just need to document at each and every step what was the present situation at that current point.
Fine. Good. Thank you.
Thank you so much, sir. Thank you, ma'am.
Who is the next person? Dr. Ruchi? Dr. Ruchi, who else is presenting now?
They have to tell them. Has given the name.
Ma'am, this is Dr. Poonam Juneja. Can I share my
Yes,
slide,
yes,
please?
Dr. Poonam, carry on.
Yes.
Yes, ma'am.
So your time starts now. Start.
Okay, ma'am, am I audible and my slides are visible?
Yes, both things are.
Okay, thank you so much, respected judges, for giving us a second chance to present. Myself, Dr. Poonam Juneja, second year resident, Department of Ophthalmology at Santosh Medical College. I am going to present a case report on thyroiditis palpebrum. So, a 25-year-old male attended the ophthalmic outpatient department of Santosh Medical College with the complaints of repeated episodes of itching and pain in both eyes since 1 month. Patient was apparently asymptomatic a month back when he developed itching in both eyes, which was intermittent and associated with watering and redness. Patient also complained of pain in both eyes, which was dull aching, intermittent with no aggravating and relieving factors. Pain was not associated with blurring or headache. There was no history of trauma or ocular surgery, fever, discharge, or use of spectacles. But the patient has a history of visiting some another hospital 15 days back with similar complaints, where he was prescribed a combination of moxifloxacin and lotepred eye drops, but his symptoms did not improve. There were no significant family and personal history. General examination of the patient was within normal limit. Coming to the ocular examination, the best graded visual acuity was 6/6 in both eyes. On slit lamp examination, the crab-like lice and number of the small translucent oval eggs were observed adhering to the eyelashes and eyelids of the patient's both eye. Multiple red pinpoint excretions, mild hyperemia, and crust excoriations were also observed at the outer margin of both the upper eyelids. The mild conjunctival congestion was present in both eyes. Cornea, sclera, anterior chamber, iris, pupil, and other anterior segment examinations examination were within normal limits. On posterior segment examination, no obvious abnormalities were seen. Intraocular pressure measured with the NCT was 14 mmHg in the right eye and 16 in the left eye. So this was the image of slit lamp picture showing the adult lice and nits on the patient eyelashes and the eyelids. On the basis of the history and the slit lamp examination, we came to the provisional diagnosis of thyroiditis palpebrum, blepharoconjunctivitis, allergic conjunctivitis, and seborrheic dermatitis. Investigations: after applying the topical anesthetic drop, the crust were removed along with the mated eyelashes, and these were sent to the lab for microscopy. Under light microscopy, it revealed a live adult form of thyroiditis pubis and their nits with the typical morphology. We sent it for the gram stain and KOH mount of the swabs, but no bacteria or fungi was seen. Culture of these swabs were given for nutrient, blood, and McConkey's agar, but no growth was seen after the overnight incubation. This was a light microscopy picture which revealed the live adult form of thyroiditis pubis with the fresh blood ingested. For the treatment part, the eyelashes were removed, including the nits, mechanically with the forceps. The eyelashes were trimmed, and local application of ciprofloxacin eye ointment were given twice daily. Oral ivermectin 250 microgram per kg stat was prescribed, which was repeated after a 10 days duration to prevent the nits developing from the adult form. Patient was advised for treatment of close contacts, improvement for the personal hygiene. Patient was also referred for the STD clinic for further evaluation and asked for the review after 2 weeks. On review, the patient showed dramatic improvement of this treatment. Coming to discussion part, since we all know pubic lice infestation contributes 1 to 2% of total human population, and it is mainly the infestation of the pubic hair, but it can also spread to the hair of axilla, chest, and eyebrows and eyelashes. Thyroiditis pubis is generally associated with poor hygiene, overcrowding, and more commonly in sexually active age group. Other two lice forms are the head louse and the crab louse. The lifespan is between the 3 stages: the nits, nymph, and the adult form. This is the diagrammatic picture. The sexual contact and the parent-child interactions are the most typical route of infestation. The symptoms associated with it include the pruritic lid margins, conjunctival inflammation, and lymphadenopathy. The treatment include the trimming of the lashes and mechanical removal, but fluorescein eye drop 20%, physostigmine 0.25%, petroleum jelly, permethrin, malathion, pilocarpine
Your
gel.
time is over. Please stop.
Okay, ma'am.
May we hand over to the judges, please, for questions?
Yeah, Dr. Poonam.
Yes, ma'am.
Do you know the use of cryotherapy for the treatment of the disease?
Yes, ma'am. Few studies have also postulated the use of cryotherapy in argon lesion therapy for the same. So in case of cryotherapy, ma'am, with the help of liquid nitrogen under the slit lamp examination, the cryotherapy is given. And according to some references, one session using 200 micron beam for 0.1 second and the power of about 0.2 watt causes the destruction of the lice and both the nits of thyroiditis pubis.
How do you think cryo helps?
Ma'am, with this cryotherapy, with the use of liquid nitrogen, it causes the destruction of these lice. It causes the paralysis of the lice.
No, what is the mechanism of cryotherapy? How actually it works? What happens? Liquid nitrogen is used, but then what happens? It has got both intracellular and extracellular activity. So now here, how does it act?
Ma'am, extracellularly, it causes the direct destruction of the lice and the nits.
Okay. Any other person wants to ask any questions?
Dr. Rustagi, please.
Yeah, Dr. Poonam, what is the other name for this thyroid palpebrum?
So crab louse.
No, that is the organism or the
Thyroiditis. So other name for thyroiditis palpebrum, right?
Yeah.
So thyroiditis ciliaris.
Okay, good. And suppose a patient, you have treated this patient, but she's coming again and again. In 1 year, she's coming to you 3 to 4 times. So what else you will do for her treatment?
So as I showed in the slide, we have to send the patient for to rule out the other sexually transmitted diseases, STDs, if he is having.
Fine. You have to ask the family history and examine her family members also.
Yes.
Very
yes,
common
sir.
thing.
Yes, sir.
Okay. Good. Fine. Thank you.
Thank you. Thank you so much, sir. Thank you, ma'am. Thank you, respected judges.
Thank you. Dr. Ruchi?
Thank you, Dr. Poonam.
Dr. Renu is next.
Yes, ma'am. Are you there, Dr. Renu?
Yes, ma'am.
And who is after Dr. Renu? One more we have, is it?
Hopefully. And no one is.
Ma'am, Dr. Vaishnavi.
And now tomorrow, there will be no more submissions, no more presentations from the first 31 whom we had posted for today. I think, Dr. Ruchi, how many 21 have presented? I think 9 in the first session, and how many in
Yes,
this
ma'am.
combined session, Dr. Monica and you?
I think 10 in Dr. Monica's and there's 2 in
now.
21. Yes, ma'am, 21.
This will be the third one, no? So it will be 21 people. We cannot allow any of them for whatever reason to present tomorrow, because tomorrow we already have enough candidates.
Yes,
so
ma'am.
thank you so much. Next candidate, please.
Dr. Vaishnavi, are you there?
Ma'am? Yes. Yes, ma'am. Yes, ma'am. Can you hear me, ma'am?
Then can I start, Dr. Renu?
Please start. Everybody is waiting.
Yes, your time starts now.
Yes, perfect.
Good evening, myself, Dr. Renu. Where is my screen?
Again, the screen is gone.
Dr. Renu, you will not get a third chance. Nobody gets a second chance in any competition, but we've given you no third chances. So please just move it forward.
My PPT is not moving.
Yeah.
Good
This is
evening,
Dr.
everyone. Ma'am, is my screen visible?
This is Dr. Vaishnavi only.
No, Dr. Renu.
Dr. Renu, Dr. Vaishnavi
Yeah,
is
it's
attending.
visible. Go on.
Dr. Vaishnavi could not present, no?
कोई बात नहीं मैडम, डॉक्टर रेणु पुनिया कर रही है, इनको करने दो।
नहीं, उनका 2 चांस हो गए हैं, अब थर्ड चांस नहीं मिलेगा, उनकी प्रेजेंटेशन इज ओवर. डॉक्टर रेणु, प्लीज स्टार्ट. We have been watching so many attempts.
Good evening, everyone. Myself, Dr. Renu, PG resident, NC Medical College, presenting case of Duane retraction syndrome with lower lid coloboma and nasolacrimal duct obstruction. You know that Duane retraction syndrome, it is also known as Stilling-Tuck-Duane retraction syndrome. It is a congenital cranial disinnervation syndrome found in 1 to 4% of the strabismic population. It is mostly unilateral, found in the left eye with predominance in the female population. Presenting the case report of a 13-year-old boy present in our OPD with the chief complaint of watering in the right eye since birth, low vision in right eye for 2 years, and slight face turned to the left side. There was no history of previous trauma or ocular surgery. On ocular examination in the right eye, visual acuity unaided was 6/18. BCV was 6/18. Eyeball, right eye esotropia was there, and there is a limitation of the abduction of right eye and narrowing of the palpebral fissure on adduction of right eye. Ocular adnexa examination, lid eye, lower lid coloboma was there with laterally displaced puncta and regurgitation was present. IOP was 16, cornea was normal in shape and size, conjunctiva was normal, pupil was circular reactive to light, lens was clear, fundus examination, optic disc normal shape, size, CDR ratio was 2 to 3, F4 was sharp, media was clear, AVR ratio was 2 to 3. In left eye examination, vision was 6/6, eyeball within normal limits, ocular adnexa within normal limits, IOP was 14, cornea was normal in shape, size, and transparency, conjunctiva was normal, pupil was circular reactive to light, lens was clear. On fundus examination, optic disc size shape was normal, CDR ratio 2 to 3, FR was sharp, media was clear, and AV ratio was 2 to 3. On squint workup, head posture, there was a 10-degree face turn to the left side. On cover test, right esotropia was there. On ocular movement, there was a limitation of the abduction of right eye with upshoot on adduction. Nystagmus was absent. On Bagoli striated glass test, right eye suppression was there. And there is a 40-degree prism diopter deviation of right eye with upshoot on adduction. And there is a decreased palpebral fissure height on right eye adduction. This is a clinical photograph showing the various gazes of the eye in primary, secondary, and tertiary gaze, showing right eye esotropia.
and there is a narrowing of the palpebral fissure on the adduction, and there is a limitation of the abduction of right eye. This is the right eye showing there is a laterally displaced puncta of the right eye. And this is a clinical photograph showing the 10-degree phase turn to the left side. For management, amblyopia therapy was done, for which patching was done, and patient was evaluated for the strabismus surgery and for endonasal DCR. Discussion. We know that DCR is one of the most common CCD, congenital cranial disinnervation disorder, and it is caused by the absence or partial development of the abducent nucleus and nerve, resulting in the aberrant innervation of the lateral rectus. It is characterized by the inability of the eye to move outward and associated with other ocular and systemic congenital anomalies. Our case is type 1 DRS as per Huber classification. For approach, if BSV is maintained with head posture and cosmosis, no surgery is required. In our case, patient has amblyopia with poor stereopsis, which was planned for the amblyopia therapy and
मारी ना वहाँ जो खाने वाला मेरा.
Thank you. Over to the judges now.
Dr. Renu, what are the tests for ocular alignment? How do we test? What are the names of the tests for ocular to measure ocular alignment? Hello?
Dr.
Renu, are
Renu?
you there?
Dr. Renu? Dr. Ruchi, is Dr. Renu audible to you? We can't hear her.
No, ma'am. No, ma'am.
Dr. Renu?
We cannot hear her. Has she disconnected or
She's gone.
or just
She's
gone
not
after
there.
presentation?
Dr. Renu?
Presentation.
Actually, I have had
Okay.
screen time of 4 hours continuously today, despite telling patients not to do this. So, Dr. Renu, 5 more seconds we are giving you.
Final call.
Madam's food is getting, madam,
Hanji.
food is,
We will
The
all be
judges will
slimmer
not be
after
able
this
to-
because no dinner.
Judges will not be able to mark it.
ये तो डॉक्टर सपन समांतर बीच में रिफ्रेंसमेंट कराना चाहिए ना सर.
ये दृष्टि यात्रा नहीं, हेल्थ यात्रा है अभी. Good.
Anyone
Dr.
left?
Renu is absent, so uska complete ho gaya present. I'm glad that she was able to present. Dr. Ruchi, do we have Dr. Vaishnavi who is left now?
Yes, ma'am. Ma'am, I'm
Dr.
here.
Vaishnavi, आपको third attempt.
कोई बात नहीं मैम, कोई बात नहीं.
Student. Serial
Yes,
numbers
ma'am.
1 to 31 will not get a chance tomorrow. We have been here for 4 hours waiting for them, calling them, and some of you have had second attempt, some third attempt. So last person today, with consent of judges, may we start?
Yes, ma'am.
She's not able to do it.
Good evening, judges. Myself, Vaishnavi Singh from Santosh Medical College and Hospital, Ghaziabad. Pathophysiology. I'm presenting pathophysiology of sudden diminution of vision in both of elderly individual. Health problems in old person, about 60
The screen is not
per
visible.
1,000 in adults.
Yeah,
Pers-
it's okay. Yeah, done. Please.
Yes, go ahead.
area and 55 per 1,000. In urban areas suffer from one or more disabilities. Blindness 1.7% in rural area and 1% in urban area. Leading causes of age-related vision loss are ARMD, papilledema, CRVO. Age-related macular degeneration include, also called as senile macular degeneration, that have bilateral common above.
We can't hear you, but just please carry on. Because change your slides at least. Okay, we'll read.
Yeah.
Vaishnavi, please carry on.
Internet issue, I think.
She is testing your patience.
Give her 4 minutes, hai na, total.
Give her 4 minutes. That's right.
2 minutes left. 2 minutes, 20 seconds left.
Dr. Vaishnavi.
I think she has disconnected or what?
I think they all have connections, I mean, issues with connectivity, no? Although I think we have in Rohtak amazing connectivity and everywhere 5G has started. So 4G has been there for a while. So I wish they would all check connections
नहीं
earlier.
मैडम, गाजियाबाद में अच्छी कनेक्टिविटी है, बच्चों को आया तो प्रॉब्लम हो रही है, आता नहीं, हॉस्टल में नहीं आता होगा इंटरनेट, ये हो सकता है।
नहीं, पर कई जगह like all our students, they know the places with best connectivity, so they sit there for webinars and presentations, na? So anyway, they will learn now. They are all new and their participation is very much appreciated. They have worked very hard, all of them. We don't know who they are, but commendable.
They are not smart as your.
No, they are all wonderful. And Dr. Vaishnavi ji. Wonderful presentation by everybody. They have worked very hard and the standard was very good. I mean, we were surprised, pleasantly surprised and impressed and very encouraged by the younger generation and how hard they're working and their insight and their perception and their presentation abilities and qualities. So great job done by each and every person.
So I think this was the final candidate.
Yes. Any more left? Any other candidates? Speak up now or tomorrow, please don't. And after this, I will not appreciate any calls at midnight and messages and pleading that, you know, let me.
Last call for boarding, huh?
Okay. Chalo ji, thank you so much to our judges, to Dr. Sapan Sumanta sir, Dr. Indra Rastogi, to madam for being here such a late time, for Dr. Sumit Sajdeva, Dr. Ruchi Dabas, Dr. Monica and Todd for hosting Mr. Sunil. I hope you are there. So it has been a wonderful session for us also. And to each and every candidate who has pitched in today, who has spent valuable time. We know you're very busy with emergencies and with all your other commitments that you have to ophthalmology. Wonderful. Thank you so much.
Thank you so much, ma'am. Thanks a lot, and thank you, judges.
Thank you
Thank
so
you,
much.
Mr. Sunil.
Good evening. Have a good night, everybody.
Yeah.
Thank you so much.
And tomorrow's, I just